last year. The recording is in progress. I'm really excited to have this day with you all. This is our BACPAC community symposium. For those of you who are new to us, I'm going to give a little bit of an introduction as to what BACPAC is, how it may differ from other prostate cancer organizations you are familiar with. I want to start with a saying in Tree, which is my parents' native tongue of Akwaba, which means welcome, right? So if any of you have been to Ghana, you've probably been greeted with Akwaba. I am Yaw A. I'm a urologic oncologist here at the University of Washington, Fred Hutch. And I'm excited to host this event. And more importantly, I'm really excited to have friends, mentors, be part of the program today, giving you all an update on some health equity research that's happening in our own backyard, and some updates in prostate cancer treatment and research that's happening here in our center. There is agenda for the day provided to everybody, and we'll try to stay on time. And then here are some housekeeping rules about what is happening today. So the event will be recorded. Virtual attendees can ask questions using the chat function. For the folks in person here today, we're going to pass out index cards so you can write your questions down as the day goes on. Those index cards will be passed to me, and I'll help moderate the Q&A. But we are a close community. If you don't have an opportunity to get an index card to me and you have a burning question, of course you can raise your hands. We do have some microphones in the room to pass around. And then we will be asking for your feedback after the event. So we will send out. We have some paper surveys, I believe, and if not, we will make sure those that are online get a survey link, which we will distribute so we can make this event a little bit better moving forward. So I have 4 minutes to get through a few slides here before I pass things over to my good friend, Dr. Dole. Why are we here? I always think about statistics, right? So people of African descent in the United States are twice as likely to die from prostate cancer compared to their peers. This is the largest disparity in any cancer by race, all right? And that's really meaningful. It's something that's been present for a really long time. We had a medical student join us from Drexel virtually to work with our UW research team, and we asked them to do this project looking at how many excess deaths have occurred due to prostate cancer over the last 50 years, right? What you see is that the excess death is actually going up, right? More Black men are dying from prostate cancer and presently than what we saw even in the mid-2000s. Probably what's most staggering is that we've lost 1.5 million years of life in the last 50 years among Black individuals due to prostate cancer. I've said this in a lot of my talks nationally, this is a public health crisis, right? And if you think about the life that we're losing early, this is the experience, life experience. These are financial pillars often of communities and families. We're losing knowledge. So it's not just a loss of life, but it's everything that it encompasses as well that we need to think about in this particular domain. So BACPAC, who are we? In 2020, 3 of us started BACPAC. The OGs, as I call them, we got Victor Tolbert in the back here. He's taking pictures, our fitness guru, now in Dallas, Texas. Dante, who's unfortunately taking class. So apparently doing a PhD is hard. And we have Ben Young, who's in North Carolina and couldn't be with us today. And we really were charged with trying to figure out how we could make a dent in this problem that I described as far as excess deaths from prostate cancer. What we chose to do was build a collaborative of Black prostate cancer survivors, people at risk in the community and allies, really focused on driving research innovation to try and reduce excess prostate cancer death. I'm proud to say we have a board of directors now. You can see their pictures. We got Ken, who's here representing the board in addition to Victor. This is a picture from the rooftop of the Fred Hutch, this building that we're in just from last month during our research summit, where all of the survivors that are involved in our projects, we have 20 now, came together with our research team to just talk through all the projects we're doing and work. We did that over 2 days. We have a virtual research community, so we built an online community of people who can make sure their voices are heard as part of the Black community. I'm proud to say we have 2,500 people in that research community. Our first survey had 1,200 responses from across the country. So the work is happening. And I think when we set out with BACPAC, we had 3 goals. We wanted to make sure we were asking the right questions. Those questions reflected the priority of the community. We wanted to develop survivors and advocates as researchers. And we wanted to design and conduct studies that would move the needle. And I'll say part of the reason we brought Dr. Dole today here is that she is doing that. And I think she provides us a fantastic model for what we can do within the prostate cancer space. I think what's unique about our team is that we have a lot of different expertise, right? I came into this line of work as a urologist, a clinician. I wasn't a social scientist. You know, I didn't have certain skill sets that were really important for making sure we could do this collaboratively. And part of what has allowed us to do that successfully has been building the right team. And this is a team. You may see some of them throughout the room today. And I have to say, none of this, progress that we've made over the last 4 years happens without these incredible researchers that are part of our UW team. So ultimately, this is what our portfolio of projects looks like. It's about $4 million of funded research from peer review funding, meaning, we have to write a proposal and a group of scientists we don't know sit in a room and debate whether or not our idea is good and whether they're going to give us some money. And each one of these projects that you see is an individual box that has survivors as scientists, engaged in the work that we do. And ultimately, we're hoping to develop, implement, and sustain solutions that work, right? And for me, the way I think about it is it's like the Beastquake run, right? We can't keep describing the problem. We got to be about that action, as Marshawn Lynch would say. All right. So how can you get involved? I think there's a lot of ways we can get involved, right? I think as patients, you can be an advocate. You can be a peer supporter, right? And we're trying to figure out how we can create capacity for folks to do that within BACPAC. You can be a patient research scientist. I think that's something we're trying to get better at, making sure that patients are always involved in a research project as an informed participant that not only provides the lived experience, but does provide some scientific expertise and content. You can be a connector. Many of you have brought friends today, have told people in your communities about what we're doing, and obviously you can contribute through philanthropy. And very quickly, I want to mention that we have really great apparatus for engaging patients in all of those things, which is the Institute of Prostate Cancer Research. It was founded by our former chair, Paul Lang. It's sustained by our current leaders, Dr. Lin and Dr. Nelson. It does have an annual symposium, which happens in May. It's a full-day program that is really geared towards making sure we cover the full breadth of prostate cancer. So that's a great venue for everyone in this room to get educated. And if you would like to know more information about IPCR, you can scan that QR code or email ipcr@uw.edu. So with that, I want to thank everyone for being here this morning. We have a fantastic program. I'm really excited for us to engage in what I hope is a great dialogue around prostate cancer and prostate cancer disparities. Now, next on our program is Dr. Dole. Dr. Dole is a gynecologic oncologist at the University of Washington Medical Center and Fred Hutch Cancer Center. Dr. Dole is a professor in the Department of Obstetrics and Gynecology. She has done that at an incredible pace, all right? And all very well deserved. For me, this is really special because when I was a young freshman at Duke University, there was someone a year ahead of me that walked the halls of the engineering program that I was in, which was hard, very confidently. And I remember always being like, man, I'm struggling, but this lady here, she's got her stuff together. Maybe if I, get up a little bit earlier and work a little bit harder, I can make it. And Dr. Dole went to Duke University where she was in the engineering program there that I was in, and then she went to medical school at Columbia. And then I was a medical student at Northwestern, and one day I go to the OB wards, and there's Dr. Dole again in charge, right? And I'm thinking, man, all right, I can't shake her everywhere I go. And then she went to UNC to do her fellowship, and then she came to UW, and then I came here for fellowship. And the first meeting I have is with my mentor, John Gore. And John's like, hey, you got to meet Kemi Dole. I was like, all right, the universe is telling me something. So Kemi has been a good friend, a great mentor. She has built something that is truly unique and incredible. And we're really lucky to have her tell us about her journey through Ikana and the sister study. And so with that, I want everyone to give her a warm welcome this morning.
Thank you very much, Yaw, for that wonderful introduction. I was going to say your slides set me up perfectly. Our presentations are very similar, except I have no football clips in my slides. And also, I was terrified every single day in that engineering program in college, but I was very good at pretending that I knew what I was doing. Okay, thank you so much. I'm really excited to speak with this group. I'm going to be speaking about community partnered research to advance cancer equity through the lens of what I know about, which is endometrial cancer or uterine cancer. I'd like to tell you a little bit of the journey of what it took to get to where we are in our research community partnership, and really our hope for the future in terms of collaborating with this group and others. Okay, so just quickly, since this is a prostate cancer symposium, endometrial cancer has a lot of similarities. It's also a cancer that occurs in the pelvis and the reproductive organs. It occurs in the lining of the uterus, or the womb. And endometrial cancer is common among women who still have their uterus. So it's about 66,000 cases a year. The lifetime risk in the United States is about 3% or 1 in 32 women by age 80. And the 5-year survival for everybody is around 80%. But that really masks a very, very unfortunate disparity. And so extremely similarly to prostate cancer, endometrial cancer is twice as deadly for Black individuals who get the condition compared to white individuals. This is a disparity that, similar to prostate cancer, has been going on for decades. It's a disparity similar to prostate cancer that is getting worse and worse and worse every year. And in addition, and I'm not sure if this is the case for prostate cancer, we actually are seeing a rise in endometrial cancer cases every year. So we have more endometrial cancer cases year in and year out now in the United States. So it's an urgent problem. And in my field, where oftentimes when people think about gynecology and gynecologic cancers, that the boogeyman in the room, the scary cancer to get is ovarian cancer. But what's actually true is for Black women, they have had a higher death rate, mortality from uterine cancer than from ovarian cancer for almost 20 years. So this is really the cancer that we need to be focused on in our community. And my approach to thinking about endometrial cancer is to take it outside of the world of cancer. Because when I spoke with Black women who have this condition, when we're in community with them, when we're doing research studies, they do not talk about themselves so much as related to a cancer identity. They really talk about their reproductive health. They talk about their entire journey of reproductive health and how this is an odd end to a lifetime of what they've experienced. Black women in their gynecologic care have higher rates of fibroids, of irregular cycles, more issues with infertility, higher rates of early hysterectomy in life. When we move on to the reproductive period, they have higher issues with preterm labor, low birth weight infants. We have higher maternal mortality, which is something that's been in the news a lot more. And then these same organs later in life, getting into the 40s, the 50s, the 60s, we see higher mortality in all of the gynecologic cancers. And this is really the experience of Black women with endometrial cancer. And so I often tell audiences, regardless of who I'm talking to, is that you can look at this and you can think, what's wrong with Black women's bodies? Or you can look at this and you can think, what is wrong with how we treat Black women? What is wrong with how we care for them? What is wrong with how we assess disease? What is wrong with how we treat it? And I choose that second lens because I think it's more interesting, but also because I do have a perspective. And I think anybody in research, especially when you're doing research that's focused on an oppressed community that's focused on a marginalized community, you are coming with a distinct perspective. My perspective is informed not just by what I learned in medical school and in training, but what I read outside of that and thinking about how gender and race and class interact in our society and how that shows up in our healthcare system and even in our bodies. So my process was just to start with trying to ask a question, which is, why are more Black women dying? Why do Black women have twice the mortality rate? When I was in training, what I was always told is that Black women just have, bad disease. This is just how it is. And so one of the first studies that we did to look at this demonstrated that, sure, it's true, Black women do have bad disease, but actually, in looking at 34,000, almost 34,500 cases of endometrial cancer, nearly half of that excess death was simply because Black women were not being diagnosed early enough to be able to be cured. And because Black women weren't getting surgery at the same rates as other groups. So that's a very different conversation than we don't really know what's going on. They just have aggressive disease. And that's really what led me to think about all the different ways that we can intervene before somebody even gets to treatment to try to get them diagnosed as early as possible so they have the best chance of cure. And this was really kind of we call it the conceptual model. This was the framework of how we really wanted to think step by step by step by step of how we can move from the time somebody has a symptom of endometrial cancer, which is often bleeding after menopause, through to the time they get a diagnosis, and what we can do along each of those intervals to improve their chances of early detection. And so I've given you kind of this research background of what we've done, but there's this entire other process that's happening at the same time, which is engaging with the community and building a real research community partnership. And so when I started here on faculty in 2016, I was trained and ready to be a GYN oncologist, but I was completely new to the idea of community engagement, though I knew it was really important and something that I wanted to do. And so over the process of my first 2 years, I really went through the process of asking patients, connecting with community members and saying, hey, I want to do this with survivors, with patient advocates. What can that look like? And I found when I looked in the literature, there weren't actually a lot of good narrative accounts of what this looked like on the ground. People would kind of show you the end point, but not the beginning. And that's really why this paper that I'm showing came to be. So what we found, in our process and connecting with these different women were that certainly our racial and our gender identity was like a motivating factor. But one of the struggles was that we had to create this partnership in the setting of these women having experienced institutional discrimination from the very institution that I was affiliated with. And how do I represent such an institution but separate myself from that legacy? We learned a lot of lessons. I learned a lot of lessons. Radical transparency was absolutely required. I think as researchers, it can be easy for us to not recognize how much vulnerability is required from our patient partners and from our community partners in sharing their stories and talking about really personal events and turning those into research questions. And so really being able to share my own vulnerabilities about the pressures of being a faculty member and the pressures of funding, like Dr. Nyame was referring to. We got to write these grants, they got to get funded or none of this happens. It really created a true partnership where they understood my vulnerabilities and I understood theirs. It was great to have overlapping identities, but it's not sufficient. It's helpful, it's not sufficient. We still come from different perspectives and we all have to respect those. And I know that my team really started to have to think about proactive mitigation strategies to account for this history of institutional discrimination. We had to think about making sure that our patient partners had parking spaces with their names on them so they wouldn't be questioned about why they were in the building. We had to think about how do we proactively smooth the process of getting them reimbursed so they weren't interrogated via email for all sorts of personal information that wasn't really required. So my research coordinators are research coordinators, but they took on this whole other entire role of simply navigating our patient partners through a system to avoid causing more harm. One of our goals of this work always was to try to convene this multi-stakeholder group. That's how we think of it: researchers, clinicians, patients, so that we could come up with an intervention to improve early detection. And we wanted to do it at multiple levels, the system society level, the provider level, the patient community level. I don't have time today to talk to you about all of the things that we've done, but I want to show you a little bit of what one of those lines of work look like. Partnering with Ecana was our method of doing that. And of course, this slide makes it seem like Ecana existed at the time, but it didn't. So this was our idea, was to partner with such a community organization in order to implement and evaluate and disseminate our work. And so Ecana was really born very similar to how BACPAC was born. It was funded through a research organization called CORI, where we asked them, there are no visible Black women survivors of endometrial cancer. So when we submitted this grant in 2017, there was not a single organization for a Black woman with endometrial cancer, despite the statistics I showed. It's like they did not exist at all. And so this initial funding, we were able to just start locating people, just start putting the word out, bringing people together virtually, connecting and creating a community. And through that, we did very similar work to what Yaw has presented, creating the organization of Ecana, building a website so people can find us, and then finally thinking about what the research priorities of this group would be going forward. We did end up creating that website over the course of a couple of years. It's now been updated, so now I have to update my slides because it's even fancier. But the reason I'm very proud of the website for many reasons. One, it created visibility for a community that had been invisible before, simply because of being overlooked, which was an unfortunate indictment of my field. Secondly, is I can't tell you how many times my colleagues, both here that I worked with, other gynecologic oncologists, but also when I would go to meetings, they would say, I send all my patients to that website. It is so thoughtful, the way that it presents information, the language. Everybody says that they learn so much from going there. And I tell them, that is great. And also, I'm not surprised, because when you when you meaningfully connect with community, you get the kind of language, you get the kind of tone that's required to meet people where they are. But secondly, when you specifically focus on groups that are doing the worst, you really attend to all of the different vulnerabilities people can have, regardless of who they are and what their background are. So what people are experiencing when they come to the website is the care that's taken across all of the ways that people can feel outsider or feel isolated when having this diagnosis. And I think that's true for all health equity research, which is why I think all research should be equity focused. After we put together this website and were able to connect with people virtually, we had our first in-person conference. So the Ecana Conference for Community Education and Research Training was the first time Black women with endometrial cancer had ever been gathered for any reason in the United States at all, which is still shocking to me. So this happened in 2019. We had survivors, we had leaders in our field at this meeting. We had clinician providers, we had researchers. And I will admit, my first idea around this meeting was really that we would come and we would train our community participants to be research advocates. So we would give them the training around research terms, make sure that they could appropriately advise studies, et cetera. And in speaking to them in the virtual connections, we realized very early that was not even close to enough. That's not enough. When our community members engage in research, they're whole people. They're not just defined by their diagnosis. And one thing that they said very clearly was like, we know research takes time, but we need to do something now. We can't have a multi-year time horizon. And so we adapted in real time in the planning of this conference to include not just research training, but also training in peer education. Because they said they wanted to go out their communities, they wanted to talk about endometrial cancer, they wanted to make a difference, but they didn't know how, and they didn't have the tools to do so. So in addition to the research training that we did in this conference, we also completed a peer education training called Community Empowerment Partners for Endometrial Cancer, which is an adaptation of work that had been done by Bridget Hempstead, a breast cancer survivor. And they were able to go out into their communities after completing this training. It was over 2 days. And they were able to conduct these peer education sessions in their own communities, and then report back to us how that process went. And I want to emphasize so much how much this was like not part of the research plan. This was an entire other project that was born purely out of our community members' passion. So they ended up talking with over 100 community attendees. They ended up getting pre and post data, survey data from us from their sessions. They ended up reaching people that, frankly, as researchers, we rarely reach. You know, almost a quarter of the people that they talked to had less than a high school education. Only half had stable private insurance. Most of them had never heard about endometrial cancer awareness, symptoms, things like that. And so by training these, what we called Icona ambassadors, we were able to increase endometrial cancer knowledge, confidence of discussing these symptoms, as well as demonstrate that we could partner with community members, send them out back to their communities across the country, wherever they were, have them conduct these sessions, collect data feasibly and successfully. And this really, this experience is what led to us recognizing we could do something even bigger. And I'm so grateful that the community members pushed me as a researcher to say, we understand you have a 4-year time horizon, but let's do something now, because it's because of their passion and their belief that we were able to launch the sister study, which we have going now, and I'll talk about. So I mentioned earlier how endometrial cancer is not just about being diagnosed early. Black women do very much have higher, more aggressive tumor types, similar as in prostate cancer. But the way that I look at this as a researcher is that this is not just DNA. Nothing is just DNA. Nothing is just ancestry. We all know that we're a product, not just of what we inherit biologically from our parents, but the communities that we grow up in, the experiences that we have, what we're exposed to. In my world, this is, combined in a theory called the eco-social theory of disease distribution, which is a lot of words, but it's simply to say that our environment impacts our biology and vice versa. And one of the messages that we heard so consistently among our community members in our early work was how isolated they were in their diagnosis. So they talked often about how they would go through chemotherapy and lose their hair, and then people would say, "Oh, is it breast cancer?" And it's not, but they don't even know how to say endometrial. How do you start talking about, no, it's in my uterus? What do people think about that? Are they going to assume I did something wrong? So it all gets shoved down in silence. There aren't communities for them to connect with. And when you combine this with the fact that treatment for high-risk aggressive endometrial cancer is not easy. It is chemotherapy, it is radiation, it is immunotherapy. It lasts for months, for some people for 2 years. It is a long haul. It works, but it's not easy. And there's very clear evidence that Black women weren't completing their treatment. They just weren't getting through all of the steps, and that impacts survival. Lastly, we know that social isolation is lethal to cancer treatment. It does not work well for anybody to be isolated going through this kind of treatment. So for the sister study, what we've decided is, well, we're going to really enact this idea of environment impacts biology. Like, we're going to fully stand on that concept. And so we decided to create a study where our interventions were actually social. Our interventions were for social support, for social connection. And in order to eventually impact treatment completion here. So recognizing that these things ultimately impact whether somebody completes treatment, and that really impacts whether or not they survive. And that is how the sister study was born, which is social interventions for support in treatment of endometrial cancer and recurrence. And what we do in the sister study is that we enroll Black women with high-risk endometrial cancer from around the country, and we collect data on them, and then we randomize them into different groups of different kinds of support. So they either get mailed materials, or they get a one-on-one peer supporter through their treatment, or they get randomized into a group. And then we follow them along to see how much they are able to complete their treatment, along with a host of other things about their quality of life, their side effect profile, their anxiety levels, all of those things. And so we went from sending peer supporters out to their communities to meet in libraries and to meet in their homes, to having a now actually 12-site randomized national trial where we're enrolling patients from multiple medical centers around the country and providing them with support during their active treatment. So I know that the reason why this study was even possible was because of all of the early work we did and the trust and the partnership that we had. When things get bigger, it doesn't mean that we lose the community connection. I think sometimes that can happen in groups, and there's a lot of pressures that make it very easy to leave community behind, but we don't do that. So this is a busy slide intentionally because it is the organizing structure of the sister study. There's a lot going on. There are a lot of people required. We have a data coordinating center. We have the intervention coordinating center. We have our stakeholder coordinating center. But every name you see in red is a cancer survivor or the daughter of someone who died of endometrial cancer. And so from our peer supporters, our director of peer supporters, we have an advocate advisory board, our stakeholder coordinating center, and onto our executive committee. Survivors are in every meeting talking about how we are running the study and how we are handling the data, and it makes our study better. Also, a lot of these survivors at this point have multiple years of research advocacy experience. And so they are able to leverage that for other opportunities. They consult on external teams. They join teams as consultants. Some of them have part-time jobs with other research teams. And we're really proud to be able to have given them that kind of professional experience, which adds to their lives in different ways as well. All of our recruitment materials are designed by our survivors. We have an incredible enrollment video, which is very important because you saw that we cast a wide net. So we're enrolling women from rural Arkansas, from rural Louisiana, from places where the entire treatment team, all the nurses, there's nobody who looks like them. So the fact that we can send them materials, they have a video to look at, they can see our faces, it makes a big difference to establishing trust. And then we can bring them into environments where they're just with other Black survivors. So it really makes a difference. I think I've failed to mention that also all of our peer supporters on this study are not just Black women, but Black women who survived endometrial cancer. So they're really talking to people who have been through what they're going through, and that makes a difference. The sister study is just the beginning. It's a big lift, but it's just the beginning. We've now created a national network of these centers. We've created a national network of survivors. We've demonstrated multiple times that we're able to do research at the highest level, and we are excited to continue that work. So we have multiple projects that are coming out of Sister. 2 of them are already up and going, Roses and Acts, which I'll talk about in a second, and there are more on the way. So the ROSES study stands for Roles of Social Change and Engagement Science. And this is really a study that came from thinking about many, many years of engaging this group, how we've changed over time, meeting different survivors and community members where they are, and really recognizing in an organized way, everybody's coming at this a little bit differently. Their perspective is a little bit different, but what seems to unite us is this feeling that this work is not just health equity work, it's social justice work. This work is about righting historical wrongs. This work is about elevating communities that have been oppressed and individuals that have been oppressed. And when we look to the literature and social movements, when we look to what we've already learned about successful and unsuccessful movements, we can actually learn a lot about how people do and don't work together well, about what different roles that people play, and how we can have more longevity on our teams and in our partnerships when we can see that, recognize it, and learn from it. And so the ROSES study is really a study to improve engagement science nationally for teams that are trying to do this in any community. And that real idea behind ROSES is that if we can understand the different perspectives, the different roles that people see themselves in, we can actually see how they assess these different areas of empowerment, relationships, the outcomes of the work differently, and specifically in relationships is where we're focused. So ROSES involves BACPAC, which is why I'm talking about it a little bit more. Our first step in ROSES was to identify these roles among our own sister team, and then go through a process of learning and kind of improving our team dynamics and work. And then our second goal is to do the same thing with the BACPAC group. So I'm very excited to continue to work with this group going forward. We actually already had our workshop with the sister team. It was right here in this room. So this is our group that came together in April, which was just fantastic. Many of our peer supporters, advocates, our study team here. We had 2 different countries represented because we got somebody from Canada, multiple time zones, lots of people came together, and it was a really fantastic time. This is just one of the many graphic illustrations that were produced from that time together. Those of you in BACPAC active in this group will hear a lot more about this, but I can tell you that the impact of that 2-day workshop is still resonating with everybody today. People have started to use the terminology. They're like, okay, I'm putting my builder self on, and this is what I think we should do. Or, my disruptor is really saying, like, maybe we need to think about this differently. And it's really, really elevated the strength of our work. And I'm excited to catalog this and then share it with the rest of the world, honestly, about how we can do this work better. Ultimately, what we want to do is to be able to almost develop these profiles where if you understand how you're coming into this kind of community engagement work, you can understand what matters to you and kind of be put in the right role so that you can make the biggest difference. We have lots of things that we do in my group. We work on early stage of diagnosis. We work on this idea of embodiment and the eco-social theory and outcomes, and we work on community engagement and trial methods. But ultimately, all of these different things we do are designed to close this unacceptable gap. So I have a few kind of closing thoughts. Engagement strategies are durable. The same things that I was thinking about doing and connecting with a single survivor, those are the same values, those are the same principles we're using to connect with our larger growing community of survivors and our larger, more complex projects. We continue to center co-learning, shared power, and trust. It's very important to constantly keep in mind, how are we helping our patient partners grow and develop? How can they use these skills outside of us with what we're doing? What can we learn from the skills that they have to bring to the table? Oh, I should tell you, I have not named a single one of my studies. All these acronyms, they all come from one of our patient partners who is just very skilled at wordplay. So sister, axe, roses, our sister, she has named everything. So that's a perfect example that there is so much shared skills that are available, but it's hard to uncover them when there isn't a foundation of trust and familiarity. We also have to think about coaching and training new research collaborators that come on board. So as our work grows, so we have a cancer geneticist that's interested in working with us. Now we have an implementation scientist that's interested in working with us. These people come on board. Sometimes they don't have any experience in having patients around the table. They don't have that kind of experience. And we have to do some pre-meeting training around language, around respect, around all of those things. And that's really important. And so I tend to say that because we have to remember that we can't expose our community partners to more to potentially inappropriate interactions. It's actually our job to make sure that the spaces are safe. I just think we must normalize funding allocation for patient and community partners as consultants. This is an ongoing struggle, to be honest. I think though it's improved, we spend probably at least 10 to 15% of the energy total in our lab group just getting people reimbursed and just getting people paid and keeping their paperwork up to date, and just things that are not, we could be doing more without that. So still fighting the good fight. Meaningful engagement is never wasted. Not every project works out. Not everything takes off. Not everything gets funded, but we learn every single time we try. This is my personal motto, which is that you can be learning and leading at the same time. And in fact, I think we all should be learning and leading at the same time. I tell that to our survivors, which is that, you might be learning a lot. You might feel like you're not really sure what's going on, but believe me, you are leading me. I need to hear from you. I need to understand those instinctual, this is going to work, this is not going to work, and why. And I feel the same way. And all of our research should be done this way, because what we know in medicine is that we will do research, we'll find something out, and it'll take 20 years to actually be implemented by people or taken up by anybody. And so if we want to start closing those kinds of gaps, then we will always narrow when we have patient partners at the table. And we will always avoid a lot of those, I think, unforced errors, sometimes that are made in research, which my personal field of OBGYN has a lot. So So I think it's important to me to do this work this way because it values and respects our community members, but it's also important because I think we should be a model for how research is done, period. Thank you.
We have index cards that we pass out. If you guys have questions, pass them down the road. We have plenty of time for Q&A. So why don't we go ahead and see what questions we have.
I don't have a Zoom here, so I think you said there was a chat, but
Yeah.
okay.
We have chat questions.
Okay. Yes. Yes, absolutely. Thank you. Thank you.
Sure. You need card, we'll get you one. One question, pretty straightforward. Do you want to ask her? Well, yeah. The annual meeting in Honolulu, right?
It was a one-time meeting in Honolulu.
Oh, I'm just asking.
Okay.
So
I'm good at
Oh, you good? Oh, that was
I'm
it?
not gonna lie, when I saw that slide and I saw Honolulu, I looked in the room and Ken's poking Kojo like when's the backpack Honolulu meeting?
You know, I will say that I am inclined to go big at the first swing, which is a characteristic I'm working on. But it was wonderful, but also we decided we should probably do it in Seattle next time. Yeah.
My boss is here if you
Yes,
guys
it
want to
was
lobby
beautiful,
him
though.
for
It
a
was
Honolulu
beautiful.
meeting.
Arranging flights to Honolulu from all over the country was experience and not to be repeated. Liz Sage, who's in the back, was a part of our team at that time and essential to making that work. She basically became a travel agent for about 5 months.
All right, I'm gonna start asking some of the questions that came from the audience. So
Sure.
the first one is, how are non-Black physicians across the U.S. learning about ICANA in order to refer to patients?
Oh my gosh, I won't stop. I won't shut up about it. Every time I go to a conference, every time, this is the last slide on my presentations, regardless of what I'm talking about. I could be talking about anything, and this is the kind of slide. So one, I do my best to elevate ICANA in multiple ways in my own work. Two, our members have been elevating themselves. So I led ICANA for 5 years. I think around year 3, we transitioned out of being a grant-funded entity to being an independent 501c3 nonprofit, really for sustainability purposes. And then 2 years after that, we transitioned. I stepped down as president, and now a survivor is president of ICANA. And so they are pretty relentless in being in every space. I'm so proud. They're so relentless in being in every space. So they get their name out. The other thing is that we've successfully made the argument of the value of ICANA and ICANA's voices to anything that the field wants to do in endometrial cancer. So now what happens is somebody will tell me, I was at the board of directors meeting for maybe our professional society, or I was sitting in this room with Merck and they were talking about this. And I was like, well, have you talked to ICANA yet? Are they in the room yet? So now we've got people who see this voice is really important and we cannot continue to leave Black women behind. How are you ensuring that? And to ensure that they have to turn to ICANA. The last thing I would say is that on kind of the clinical practice side, I did not talk about any of that work, but we do a lot of work around first surveying providers and identifying that there are these gaps about endometrial cancer knowledge, but now doing a lot of dissemination of some of our research work around how we can improve early detection for Black women in our clinical spaces. So yeah, it's important because only 3% of GYN oncologists, my field, are Black, and that translates to like less than 30 people in the country. So we have to educate everybody.
Love it. I mean, there's something to be said about the grassroots nature of it.
Yeah.
We're seeing it with BACPAC now as people get the word out among themselves too. So I think it's a great question, kind of tied to sister a little bit. And this is really about social support. So how much of treatment completion in your experience is tied to supports from employment? I.e. if someone's employment does not give them time off or make accommodations, they can't complete it. FMLA guarantees your job, but not funding. You have any thoughts on that?
Yes, I have so many thoughts about that. So the median age of diagnosis of endometrial cancer is 63. And so I would say about half of our participants on Sister are employed and about half are retired in some way, shape, or form. Another thing that we are measuring is something called financial toxicity and people's ability to meet their monthly expenses. So they let us know that, initially, and then that's something that we're following over time. So one thing is that we're actually capturing that information of how much I stopped going because I literally can't afford to do this anymore. I can't afford a ride. I can't afford those kind of things. The second thing is one of the things that we're hearing from the peer supporters is how much community problem solving happens in these groups. So these are the things that are hard to measure, which is why we're doing interviews as well. But, they'll maybe come together to talk about nutrition, but somebody will mention, I'm really stressed out because my FMLA is running out and I'm not sure what to do. And somebody else or a survivor on the call is like, oh, this is what I did. You should do this with HR. You should think about talking to this person, et cetera. So there's all of these other, almost softer or kind of indirect ways that the community is accessing problem solving, kind of group problem solving. So I do think that this is a big issue. And I don't think it's just about employment. It's also about caregiving responsibilities. The number of these 65, 70-year-old women who are raising grandchildren, like my 5-year-old grandson, my 10-year-old grandson lives with me, who is taking him to the bus when I have to go get chemo. It's not insignificant. So that's another thing that we are looking at as well.
And I think it's a great question. We'll have some follow-up from our OCOE team on some other things that may be ongoing in our cancer program that we're trying to address this specifically.
Yeah.
Last question I have for you is a tough one, and it's directed at both of us. So I'll have you answer first, and then I'll just agree with you. What can I do to inform Black men and women at my street ministry about getting testing for early detection? So
Oh, this is not hard at all. This is what we're doing right now. So first of all, you should tell them to visit the gracecenteruw.com. And if they click on Guides by Us, we have a whole program, public facing communication toolkit called Guides by Us, because it's like guiding you by ourselves. It's Black led. And it has a ton of information on early detection of endometrial cancer, what it is, what the different words mean, what symptoms you should be looking out for. We're on Instagram, we're on Facebook, we're on Threads. We had to get off Twitter for obvious reasons, but we're on all of those platforms. There are videos that are starting to be rolled out now. So what we're trying to do is not put the burden on an individual, for example, in street ministry to know everything, but to be able to pull something up on your phone, send it to somebody and be like, check out this video, or send this video to your mom. Send this video to your aunt. Make sure that she's just aware of this, that she knows about this. In the same way that I think we have a lot of normalized public dialogue around things like breast cancer. We have a lot of people know if you feel a lump, you got to go get checked. But most of the women who are diagnosed with endometrial cancer, they say, nobody ever told me that if I had a little bit of spotting at 70, I should run to the doctor. But that's also true. It's the same thing. So we're trying to normalize the conversation as much as possible. If you want a little soundbite right now, I would tell you that you can ask your aunties and your moms and your older women in your community and all that, and make sure that they are still getting their gynecologic health checked out. You could just say, don't forget, there's a lot to gynecologic health after the babies come out. You should always, maintain and get that checked out, because we have a problem right now where we stop thinking about gynecologic health after a woman is not in childbearing years. And that's unfortunately why there's so much opportunity for people to have cancers grow undetected.
And I think on the prostate cancer side, I will just add that in the work we have done, we know that there's an awareness problem, and there's a power differential problem between the patient and the primary care provider. And then there's an access problem. So we are trying to address that. We have a project called Combat PC. Some of you guys are on it, where we are building a similar tool to help get the word out and spread the information. But I think normalized conversations about the risk, right? A lot of Black men who are at risk are unaware that they carry a higher burden potentially.
Yep.
And so I think we are trying to help facilitate those conversations. But this is for us, it's a hard thing to do, because some of the tools we rely on have become controversial unnecessarily in mind. Right. Was that a question from you?
Yeah, that was my question. I do street ministry work, and I've been on the streets of Rainier and Henderson for 12 years.
Okay.
So we feed the homeless, we clothe the homeless. And so I hear what you're saying about going to a computer or something like that, but we deal with Rainier and Henderson, if no one knows us, right in the heart of the Black community. And we have more young Blacks and young women, Ethiopians, Africans that come by our way, you know. So what can I do? Because they don't have access to these things. So after hearing everybody and hearing all this, so what can I do to maybe get them to at least think about getting tested, or for the men and for the women, think about getting tested? What age should they do this? Because I'm willing to be an advocate for this out on Rainier and Henderson. So we've been out there 12 years, and we deal mostly with Black, men and women.
Perfect. I think so for endometrial cancer, the average age is 63. So we try to think about any woman over 45 is about the age that we start being concerned about it, but much, much more likely in their 50s, 60s, and 70s. And I really think even a single, if you haven't had a gynecologic checkup in a couple of years, you should go. That alone would do massive amounts of work. I don't even know that you have to get more detailed than that, because once they get in, then they'll get asked all the questions. But then what is normal is that women don't go at all. So just getting people in and saying, you can really leave it as, I noticed, your kids are older, that's really good. Make sure that you still get your gynecologic checkups though. If you haven't gone in the last few years, you should go back just to make sure everything's okay. That's how I would say it.
And I would love to connect with you in our next break so we can exchange information. I would say our message is similar. At age 40, have you thought about a PSA? Right? Age 40 to 45. And I don't think you have to have an agenda of go get tested, but at least plant that seed.
Plant the seed.
And have people start to think about it.
Yeah, it's part of your health.
It's a great question.
Yep.
The last thing is, when are you guys going to start a picana? They want me to copy you exactly.
A picana. Now, Yaw been on my tail. Yaw has been on me my whole life. And you want a picana now too?
I will say prostate cancer is blessed with a lot of organizations that do advocacy and support, right? So we as BACPAC have partnered with those groups like the Prostate Health Education Network, FEN, Zero. So we didn't have to create a space from scratch like Dr. Dole did, which is why we really focused on BACPAC being an arena for research advancement. So with that, I just want to thank you again, Kemi, for being here today, for sharing your story.
Thank you all so much. Thank you for being here.
We are going to transition our program now into some updates in prostate cancer care and research. As I mentioned earlier, we have our IPCR Symposium where we go through a lot of, prostate cancer care in great detail. So we really wanted to focus this session on what our cancer center is doing that are updates, either in care or research, and a little bit of some updates on a lens towards health equity. So our first speaker is Dr. Marah. She's an assistant professor of urology. And similar to everyone else who has been invited to speaker as a close friend, Dr. Hehemann and I first met in Chicago when I was in medical school. We were both sub-interns, meaning we were both trying to get a job at Loyola University as medical center. And so we met then and have stayed in close contact and have been fellows together. And when we had an opening for the type of work she does, kept bugging her. I was like, hey, have you applied? Have you heard about this post? And luckily we were able to bring her back from Chicago, her hometown, to Seattle. So with that, Dr. Hehemann, thank you so much for being here.
Thank you so much, Dr. Nyame. Yes, we do go way back, and we have the honor of sharing patients now, sharing, conversations about our work, about our lives, and certainly about the important topic of prostate cancer survivorship. So I'm super honored to be here. And this will be kind of a whirlwind tour of survivorship. This is meant to be a message of hope and a message of, how we get beyond just cure and we return to sort of life as usual. So first, some statistics on survivorship. By 2040, there will be over 26 million cancer survivors in the United States. So this is a huge population of patients. We have great treatments, but the care of cancer survivors is sort of an afterthought. It tends to be fragmentary, and it's not always well integrated into the mainstream of cancer culture. I'd like us to consider who are survivors, because it's not just one person. Of course, the patient is the primary focus of survivorship, the patient with cancer who's going through the main treatment, but we have to think of survivors as everyone around them as well, because they're not experiencing this alone. The partners of cancer survivors are absolutely intimately familiar with the changes they're undergoing, the emotional ups and downs of diagnosis, treatment, and cure, and then, side effects. And so these partners are also really important. And I think we heard from Dr. Dole that it not only impacts just the intimate partners and the patient themselves, but also the entire support network, people at work, how you show up on a day-to-day basis. Everyone can be really impacted. So we think of everybody. I also like to think of survivorship in this sort of hype cycle. So this is a diagram that was developed to describe the development and adoption of new technology. So for things like startups, where there's an innovation, people get really excited about it, and then it's like, oh geez, this is really hard to achieve, and then there's some leveling out. And so I saw this at the IPCR, and I think it really sort of gets to the heart of cancer care as well, because when you first get a diagnosis, you're at this very low point. You're just at the tip of the iceberg, hearing something really down, and then you start to learn more, maybe engage with some of the communities you have here to learn about the treatments, the amazing teams we have to support you. You get more and more elevated, you get excited about the treatment, you're going to get through it. You have your maybe surgery or treatment, and then now you're undetectable and you're at this sort of peak of expectations. But now you realize that you have some side effects from treatment, because most cancer care and cancer treatment has some side effects. So then I feel that people go into this sort of trough of disillusionment about how do I go from here? My marriage has been impacted by this. My day-to-day life has been impacted, my energy levels, etc. And so part of my job as a men's health specialist is to get patients back on this slope of enlightenment, to try to educate people about where we go from here, what treatments are available, how do we get you back to maybe not your old normal, but a new normal. And then we get to this nice plateau. So it's a lot of ups and downs, but we as a team can help support you throughout the entire journey. Part of the survivorship journey is understanding health-related quality of life. And so it's not just about cure and treatment, although we'll hear amazing things about what's at the forefront from our next speakers. But health-related quality of life is the focus on an individual's overall well-being, including the physical, mental, emotional, and psychosocial functioning of just the patient, as well as all those people around him that I talked about before. And in prostate cancer, and specifically, there are sort of 4 domains that I want to focus on that pertain to side effects from treatment that we can really address to get you back on that slope of enlightenment. And the first one is sexual function. So just to kind of broadly look at the entire United States, this is not specific to prostate cancer patients, but this just looks at, as guys get older, sexual function declines. It is sort of a fact of aging, and prostate cancer patients, of course, are in these lower bars here, the age, typically 50, 55, 60, 70, and they fall into the category of many, many American men that have some difficulty with sexual functioning. And just to remind everybody of the anatomy of sexual function, it's really just hydraulics. So we go back to high school physics, we get fluid coming in, and fluid coming out. Of course, that's really dumbing down what the sexual experience is. And it's so much more than just hydraulics, but that's sort of one way to think about it. When we think about, this is a busy slide, what I'll just put up here, but it really gets to the point of that we have so many tools in our toolbox to help with the entire sexual experience, not just hydraulics, but also the intimacy aspects that may have changed after cancer treatment. And so this is from our AUA guidelines, the American Urologic Association, where we have sort of a baseline treatment strategy of recommending some modifiable, making modifiable lifestyle changes like quitting smoking, doing things to make you healthy in general, perhaps making some medication changes. We're already here in this yellow bucket on the left, which is counseling and education. And that's really a big part of my job as a urologist, is just educating patients about what options there are, because it is entirely up to men about what makes sense for them. Some guys may want to just try pills to help with their sexual experience. Some may really get side effects, so they may need to move on to other things. We have tools as deep as surgeries that have been around for over 50 years to put in a penile implant. And now we have some new technology at the fore that I'll get to in a few slides. So back to our health-related quality of life. The second topic that comes up probably most often when we talk about prostate cancer treatment is urinary control. And there's some good news here. So this is from 2019. This is looking at open prostatectomy versus robotic prostatectomy, which is the majority of how prostates are removed for cancer nowadays. And what you see here is that over time, the vast majority of men regain urinary control. So the vast majority of men are dry after treatment and satisfied from that aspect. And there are a proportion of men that aren't, though, and we have excellent treatments for them. So that's not something that if you see your doctor and you are struggling with this, you should feel that there's no hope. We have many, many things. And again, it's sort of this tiered approach where we have counseling, education, support. There are tools like physical therapy. There are tools that you can just wear day to day. And then there are more definitive treatments. These treatments, like surgeries to treat urinary leakage, have also been around for many decades. They're very well researched, very well established, and really are truly some of the most life-changing things that I do as a surgeon. I also mentioned that there are new approaches here as well. So let's take a look at some of the new sort of surgical things. When you talk to urologists, you're talking to people who love technology. We love sort of integrating new stuff, lasers, robots, you name it. And so in my area of prosthetic urology and men's health, here are some exciting things that are on the fore. So I mentioned that from a sexual function standpoint, we have technology like penile implants. These are again, have been around for 50 plus years and are finally developing a very new integrated tool to make them Bluetooth compatible. So for 50 plus years, I know, there are many jokes we can make. For 50 plus years, these have been mechanical. But they're very far along in the research and development of a Bluetooth compatible device that would allow things to be hand-free, allow things to really come into the next generation. So many jokes around that, but not funny. It's coming. Okay. From a urinary control standpoint, there are a few different exciting things on the fore. So here is showing you a bulking injection. So for guys who are leaking, sometimes we just need to support the urethra and kind of tighten things up a little bit. This is an injection that's been used for many, many years for women who have leakage, like after childbirth, and now we're starting to apply it in men. It's minimally invasive, and there's some promise here. Second is, I mentioned two kinds of devices that have been around for a long time. This is a new one that is being used in the United States and having really good response, where these just small balloons are inserted right at the base of the bladder where the prostate's been removed and can tighten things up to provide more urinary control. So lots of exciting things. Finally, going back to our health-related quality of life, these two topics are also really important pieces to survivorship, the emotional and physical well-being more broadly. And for a long time, we've had amazing tools like support groups. You guys are here, you're learning, you're all part of the community that's helping with this approach to wellness, physical and mental health. But what's new? The new things in this area really lie in the digital therapeutics. These are apps. These are apps that you have on your phone to help you not only track your treatment, but track how you're doing from a mental and physical standpoint. Did you get your exercise today? How are you feeling? And they've been shown to be really helpful to reduce anxiety. So going back to this, these are many studies that show that these stress management apps can help men who have cancer. Here's one about anxiety and depression. This is looking at an app that's specifically for breast and prostate cancer. This is an example of one of these apps. And then this is what I just found recently, is that a researcher at the University of Oklahoma is also researching an app specifically for Black men in prostate cancer post-diagnosis. So lots to think about here. I wanted to just show you where I sort of do my work. This is the University of Washington Men's Health Center, kind of just a few blocks away from where Dr. Nyame works at the main hospital. And this can be one stop on the survivorship journey. So this is where we do a lot of teaching, a lot of work with men who are survivors, and it's one of the most fulfilling parts of my job. So again, very happy to be here and happy to take any questions. Thank you.
Just so everyone is aware, I know there are going to be a lot of questions after each of these speakers. If you need more index cards, raise your hands. We're going to have a panel for about half an hour where all these questions can be addressed. So our next speaker is going to be Dr. Daniel Lin. Dr. Lin is professor of urology at the University of Washington, Fred Hutch. He has a lot of titles, too many titles for me to read, but probably the most important one is he is now the interim chair of the Department of Urology as of Tuesday of this week. So congratulations.
New rules. Thanks everybody. Yeah. I know many of you, and I was fortunate to be here last year for the first, and now here we are the second annual. Just really congratulate Yaw and you all and all the team for putting this on. Just been really fortunate to do this for you all. I was tasked with spending the next 15 so minutes on some things with earlier prostate cancer, particularly like clinically related, what's new clinically, and then kind of what we're doing research right here at the center. And I'm going to start with a vignette about active surveillance, which is early prostate cancer, and the amazing talk by Dr. Dahl. Man, that was amazing. You'll see a little similar venture that I've led for the last 15 years. Because I think we all know that cancer, and I've said this before, unlike men and women, not all prostate cancer is created equally. Right? There are different species of prostate cancer. And I will say there's some prostate cancers that are like the turtle on the block, and it's all called prostate cancer, but then there's some prostate cancers that are very aggressive. And again, it's all called prostate cancer. So the very first thing when I have a friend or a family member or somebody say, I have prostate cancer, I need to talk to you, I say, well, what kind of cancer is it? They say, oh, I have prostate cancer. I say, well, no, there's a lot of different types of prostate cancer. And so one of the first things we do is we look at the grade, and then there's PSA, and many of you know this. And so about 15 years ago, Pete Nelson, who's in the back of the room, you'll hear from him. Pete Nelson and I were here at the Hutch, and actually a donor came and said, I want to start a study on prostate cancer detection. And we said, well, we can detect cancer pretty well. And you're going to hear from Dr. Etzioni later about how we detect prostate cancer. But we said, we want to learn how to treat it better and who to treat. And we're going to start with a group of individuals who are diagnosed with prostate cancer that looks like the turtle on the block cancer. And I'm going to show you a little bit about how we determine that. And so we started a study that we've been going on now for 15 years. And this is just a schematic, and this sort of looks like Dr. Dahl's map of the North America. And now we're many years later, over 2,000 patients who are diagnosed with what looks like a very slow cancer that we thought at the time, let's just watch it and not treat it. We'd say, you have cancer, but we're not going to treat your cancer, which was at the time revolutionary. Like, why would you treat my cancer? but we learned that we don't have to, and I'll show you why in the next few slides. So we started this study. Now it's 10 sites across North America. And again, it's the way we do it in this complex slide, but I'm going to simplify it by just saying men come in and they're told that they have basically low-grade cancer. We call it active surveillance. Oh, I guess you can't see that. When they come in active surveillance, we just follow them along serially, do exams, do PSAs, do biopsies. Some of them what we call reclassify. In other words, their cancer looks a little worse, and I'll tell you about that in a minute. And then we just have been following. The most important thing is we see what happens to them at the end of the day. They're on the right of the slide. Do they die? Do they have cancer recurrence? Do they get treatment? And all along the way, our group was really interested in biomarkers. So all along the way, we got blood samples, urine samples, tissue samples, all and had them all sent here to the Hutch. And this is where we're doing a lot of our research. So I'm going to present that second. But first, I want to tell you about what's really come out this year. And we just published a paper this year in a high impact journal talking about our experience with active surveillance. And this is what I'm talking about, why not all prostate cancer is created equally. Because if you look on this, this is the spectrum of prostate cancer from the left to the right of the slide. And the grade is that number grade down there. And there are two different grading scales. One goes 6 to 10 with two different 7s, and one goes 1 through 5. To me, it can be simplified by saying most of us thought that this is the line. Anything a grade group 1 or a 3+3 was not really cancer almost. It was very benign. And when we talk about reclassification, it was going up this way on the slide, getting worse cancer. And the majority was right here. All right. Now, about 5 or 6 years ago, it came about that, hey, maybe that cancer, that number 2 cancer, there's not that aggressive. Maybe we can actually still watch those. And so we started drawing the line here a little bit more and saying, it's okay to be one of those two, but up here, we call it extreme. All right. And I think that gives you an idea of the spectrum of prostate cancer. There are those that are kind of slow and then some we really want to act on. The question was, how safe is it to watch? Which brings us to this year, and this paper just came out a couple months ago, and this is Lisa Newcomb, who's been my partner, a scientist here at the Hutch and at the UW, and she's led the program. I just want to give her credit. And this just was published this year on our long-term outcomes of these 2,000 patients that started with this turtle on the block cancer, and then what happened to them over time. I'm going to summarize it. Well, first, who are they? They're the typical patient that has prostate cancer, a little younger for prostate cancer, 63. Now, mostly Caucasian. And so we've been trying to really work on this and again, work with your group as well to try to have more representation. Mostly men with PSAs that are pretty low, and almost all of them had that grade group 1, 3+3 cancer. So how they do, we followed them for about 7 years. Actually, it's been a 15-year study, but on average about 7 years, a third of them went on to treatment. So a third of them, despite looking like this little turtle on the block cancer, eventually looked worse. We treated them. Interestingly, many of them actually had what we call adverse pathology. So there were some patients that looked like they had worse cancers even after we treated them. But then the money is this. Only about 9% of those that got treated had a recurrence. And out of the 2,000 patients, 2,100 patients, we had 21 patients that had spread of disease. And to this date, only 2 cancer deaths, which is, if you think about it, really, really low. Much less than 1%. So this has really developed the safety, and I'm happy to answer questions about it. I think that we look at these kind of curves, which is the way that in the medical literature, we like to look at it. Like the orange line is, or yellow line is how many people got treated over time. Okay, good. And that's how many people got treated over time. And if you look at about the 10-year mark, about half the people are getting treated. And again, I think part of it's because they have worse cancer. What down on the bottom there, I think, is the worst one, like extreme. You don't want anything extreme. And it can be almost 1 in 5 over 10 years. But truly, when people ask me, if I start this, am I going to die from prostate cancer? It's pretty low. I mean, if you look at here, over time, there were 2 deaths out of 2,000 people. And the metastasis, you can see there, about 1%. And the all-cause mortality. So dying of a heart attack, a stroke, another cancer, an accident. Look at that. That's much higher than the death from prostate cancer by many, 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 many fold, right? So I think that we've developed a safety. This is one of the figures in the paper that I do actually want to show you, because Each little row is a person out of that 2,000 people. And the top there are all those people that nothing ever happened to them over time, a full 10 years. I mean, nothing did. We did biopsy, nothing happened. The very bottom down there is those that got recurrence, and I want to show you those. These are the people that got recurrence after being treated, and all the little triangles, the little open triangles are biopsies that they had. So there are people that might have a biopsy, and then they got treated. And then eventually they got recurrence. It's only 60 people. These are the ones we really want to avoid. Only these 20 people out of 2,000, okay, 1%. And again, some of them got biopsy, treated, recurred, eventually had spare their disease. This is what we want to avoid. And I always put it in these terms. I say, if we take all the men, all these men, at least half of them never had anything happen to them. We can probably not do much, like we call de-intensify surveillance, okay? Maybe you just watch them, like not tell them not even get biopsies or PSAs. These are the ones we want to find and say, don't do anything. Like don't do surveillance, go to get treated, get radiation, get surgery. And these are the ones that are toss up. And I think this is the battleground in my opinion, okay? These are the ones that we should do things to find better biomarkers, better ways to detect these people, figure out who these people are, okay? So I'm gonna just transition here for the last couple of minutes into what we're doing. We're doing a lot of different things. We're taking those blood samples, looking at their blood markers, but we're also looking at newer ways. One of the ways is basically taking the past, which is, again, this is sort of a microscope in the very first microscope, okay, 1600s. And then now we have a microscope, that's the past. What are we doing now? We're doing scanning slides in. We're using artificial intelligence, computers, to try to figure out who to treat. I mean, this is sort of a tongue-in-cheek. You know, we're not gonna have a robot looking in a microscope, but we're taking the images and we're using the images to do standard tasks as well as maybe more advanced tasks. Because every cancer diagnosis, and these are slides I got to credit Dr. Hafner, one of our colleagues here. Every cancer diagnosis starts with the pathology slide, right? A piece of tissue comes out. They look at that tissue and they say, oh, there's little patterns. This looks like cancer. Well, can we train a computer to do that? And indeed, there is actually one of the first FDA approved models that we trained a computer to take the images on the bottom part here and segment them into classifiers and then say, is it cancer or not? And then even what grade cancer it is. And again, this is now approved. It performs pretty well. It's not going to take the place of a pathologist and read and diagnose people, but it certainly helps aid in that. But can we go to the next step and can we train a computer to say, can you just recognize which ones, they're all prostate cancer, but for sure there's the bad ones down on the bottom and they're the good ones on the top. And we know that over time, it translates to worse outcomes if you have the lower one. To be candid, there are a lot in between. Okay, so we're taking the extreme examples. And can we say to a computer, show us the extreme examples? And not only that, again, this is what we want to do. And this is Dr. Hafner, what he's doing in his lab. He's taking those images, but he's also looking at genes and DNA and molecular signatures and putting them together. They're going to talk to each other in a kind of machine learning way, and then hopefully spit out outcomes and improve our care of patients. Okay. There is already, and I'm showing this already, a commercially available, they call it Artera AI for Artera Artificial Intelligence Prostate. It does come out with a score. It's on what we call the NCCN guidelines, and it's right there in the middle. And our group here at the Hutch is working with this company in that past cohort that I just showed you. Okay, so those 2,000 men on active surveillance. So we're going to try to make some headway and do that. I think the future really is in what we call liquid biopsy, and I think precision medicine and Dr. Nelson will talk a bit about this, but just one slide. You know, a biopsy needs an invasive biopsy. This is, you take a blood sample. In the blood sample, you can see all sorts of little proteins and so forth that are shed from the cancer that are just circulating around the body, and we're working on this. Dr. Ha and Dr. Pritchard are. So I'm going to end with just a little bit more mundane technological advance. This week, we got the newest generation of robots, or last week got delivered to the University of Washington. They're called the DV5. Dr. Gore is not a robot, but Dr. Gore there, just because he's actually the chair of our robotic committee at the University of Washington, was really instrumental in getting these machines to us. Are they groundbreakingly different? No, they're not different, but they do have improved things like, believe it or not, they can actually, if you have a robot, we couldn't really feel. So Dr. Nyame and I do a lot of these surgeries. You can't really feel tension, but they actually have a little way that we can actually, what we call force feedback technology. There are better ergonomics and so forth. And then we can actually capture data easier. So they've really upped the game, and we're really happy to have these robots here at the University of Washington, in the first in the state. So I'm going to end there, and I'm just going to go to the end here. Active surveillance, we know for lower risk prostate cancer is the preferred initial approach. It appears safe. I think artificial intelligence, machine learning is going to have an increasing role. We're hoping that it has promise for advanced applications yet to be seen. I pause here and say that Dr. Hehemann slide, we're at that kind of peak of enthusiasm. We're going to kind of come crashing down probably, and we have to figure some things out. I fully recognize that. Okay, but we're out there. We're leading the edge. We're leading the charge here at the Hutch, and we're very happy about that. Robotic improvements, and we have, of course, personalized medicine approaches. So, thanks so much.
So again, raise your hands if you need an index card. We can pass them around if you have questions. Next, we're going to have Jean McDougall. Dr. McDougall is from the Office of Community Outreach and Engagement here at the Fred Hutch Cancer Center. I'm very lucky to have a role in OCOE and work with her and Dr. Mendoza, who's in the back. So she's going to talk a little bit of different pace as far as walking away from the clinical side of prostate cancer, but talking about a social intervention project that we have through OCOE that's really important. And please write down any questions you may have about this, because I'm sure the team would love feedback from you all. Thank you, Jean.
Thank you so much. So yeah, I'm Jean McDougall. I am not a clinician. I trained here, and I'm an epidemiologist and cancer care delivery researcher. And I'm going to talk about a study that we have going on through the Office of Community Outreach and Engagement here at the Hutch that's really around increasing diversity and inclusion in clinical trial enrollment. So as you guys probably know, only about 7% of patients with cancer participate in clinical trials. That's true nationwide, and it's pretty similar here at Fred Hutch. When we talk to patients about why they don't participate, of those who were offered, many talk about the fact that participating in a clinical trial takes a lot of time. They're not always given clear expectations of what's involved. You wouldn't take a job if you didn't know what was being asked of you, but sometimes you're asked to participate in a trial without really being told what's going to happen in that trial, right? Travel to the clinical trial site. If we're asking patients to come into Seattle multiple times a week for multiple weeks, that's a huge burden, right? There are many concerns about cost and fear of side effects. There have been many papers that have been published looking at how there are multi-level barriers to diverse clinical trial enrollment. These are on the part of the clinician. Clinicians aren't always offering clinical trials to all patients. We talked about some of those patient barriers just a second ago. The trials themselves often have exclusion criteria that say, if you have past health conditions, you're not able to participate. And there are institutional barriers. We charge a ton of money for parking, right? So there are things that keep people from participating in clinical trials that we can address. And one thing that we're really focused on in the Office of Community Outreach and Engagement is thinking about health-related social needs and how these play in. We talk a lot about trust and education, and these things are important, but sometimes we don't really get to the sort of reasons why people aren't participating, like transportation. It's a problem for a lot of people getting to clinic. Having healthy food and affordable and stable housing, affordable utilities and personal safety, all of those social things and the social support and the things that are necessary to really do well in your treatment, if we're not addressing those things, then offering people the best clinical trial that's available isn't going to do that much, right? We need to be thinking about the social conditions in which people work and live and play. So We recognize that multi-level barriers require multi-level solutions, and we looked to the American Society of Clinical Oncology and other boards that have really put out some recommendations around how to increase participation in clinical trials. And those were really to screen every patient for clinical trials, make it a systematic part of clinical care instead of leaving it up to the oncologist to introduce a clinical trial to patients who they think might be interested in participating. We also want to collect and analyze data by patient demographic characteristics. We're looking at who is being screened for clinical trials, who then participates, why people don't enroll, and whether they're actually retained over the entire part of a trial. Because it's not just getting on a trial, right? It's making sure that we support people to stay on trials. And then investing in programs and policies that increase DEI in clinical trials and the research workforce. So these are kind of some of the recommendations that are out there. What we did is try to develop, and what we're working on is a clinical trials navigation and reimbursement program. So right now at Fred Hutch, there are research nurses in the prostate cancer and GU oncology clinic that systematically screen all patients for open clinical trials. Before a patient even comes into the doors of Fred Hutch, they're looking if they have they've called in and they say there's a new patient coming. The research nurses are then looking at all of the open clinical trials and saying, based on what we can see in this person's medical record, it looks like they might be a candidate for the clinical trial. Oncologists and research coordinators then introduce those trials to participants when they come in for their initial visits. And the part that we're really building is this navigation piece, where a navigator can then meet with patients who are considering clinical trials and provide some extra support around that really important decision. So the guide intervention includes that initial meeting with a clinical trials navigator, where they review the trial and scope of participation. As I said, really understanding what are those job expectations before you take that job of being on a clinical trial. We want to identify any barriers to participation. So that's really around the social needs piece and looking at whether people have needs that could be met to really increase their participation. And then what is unique about this is this reimbursement piece. So recognizing that sometimes what people really need is the extra financial assistance or the reimbursement for the costs that they're going to get for participating. We can reimburse up to $2,000 of trial-related expenses. Those are for things like transportation, that expensive parking we were talking about, lodging if you need to come into Seattle from outside and stay here for the clinical trial, food, childcare, elder care, and out-of-pocket costs. And then there's 6 months of ongoing navigator support that's provided. And so this is the intervention that we've developed, and we're testing it out right now to see whether it increases trial recruitment, enrollment, and retention. So we want to develop and pilot this clinical trials navigation intervention. And what we're really doing, we spent the first year of this study just developing guide. And I'll show you, we talked to patients and providers and thought, how are we going to fit this into what's already happening at Fred Hutch? We're now in this new stage where we're piloting in a randomized clinical trial the guide intervention, and we want to measure whether it increases recruitment and retention. And then third, we want this to be a sustainable program. And in order for it to be sustainable, we need to quantify how much does it cost to provide this extra $2,000 of reimbursement, the time of the navigator, the time of the patients who are participating in this, and getting it into the clinical workflow so that we can make it a sustainable program going forward. So I mentioned in that first phase, we did some qualitative interviews with 20 patients and 19 providers to really understand what it is they wanted to see in a clinical trial navigation program and how it might work. Providers talked about how they saw this value of a dedicated navigator. You know, the clinicians are super busy, having somebody else who could take that piece of really sitting down and taking the time with patients and their families to talk about the clinical trial would be great. They agreed that financial resources for patients were super important, but there were some concerns about providing financial assistance. So right now, clinical sponsors sometimes cover some reimbursement around clinical trials. So they wanted to know how our program would fit in with the sponsor reimbursement. And they talked about how reimbursement probably isn't the best model, right? Reimbursement means you pay up front and then I pay you back later. That means that we're assuming people have the money to pay up front, and we're not going to get people who don't have a credit card that they can put that money on up front. It's not the best model. The reason we went with that is because there were also concerns about this idea of inducement, or if we said, here's $2,000 to be in our trial, it might influence people's decisions around clinical trials in a way that wasn't, the Fred Hutch said, no, you can't do that. Now we're working on that, and we would like to move to that sort of a model because of the limitations of reimbursement that I talked about, but we're not quite there yet. Patients thought that clinical trial navigators could better explain the purpose of the trial. They wanted somebody to be able to talk about the medical terminology that there's in those consent forms and what does that really mean, and is there somebody who I could talk to about all of that before I have to sign it, and the scope of participation, really understanding how long am I going to have to be on this trial, how many times am I going to have to be in the clinic versus if I don't do the trial, and walk through kind of that calendar of trial participation. Often patients talked about the need to build trust between patients, family, and the research team. Patients are offered trials, right? But you go home and you talk to your family about whether you should do this. And having a navigator that can talk not only to the patient, but to kind of everybody who's involved in that decision-making was important, and building the trust, if there are questions, to go back to the research team and have someone to really advocate for you was important to patients. And then having someone to address individual barriers to participation. In research, we think we read lots of papers about the different barriers, but patients say, my situation's unique. I want someone who's going to ask me about what I may have to navigate in order to be part of this. So we've moved on to now piloting this randomized control trial of that intervention, the navigation intervention. So we're currently enrolling 100 patients at Fred Hutch. We're looking for people who are 18 years of age or older. They have to be considering an open clinical trial that research nurse identified or their oncologist identified. And as I said, we're really targeting people who have at least one health-related social need. So we have social needs screening, where we're asking people about transportation, food, housing, financial challenges, and looking at whether we can really support people who might most benefit from this. At the moment in this pilot trial, we're only able to collect or enroll people who speak English, but we are collecting information, and as we iterate, we will start to offer this in more languages. But everybody does a baseline survey, and then they're randomized either to the guide intervention or usual care. They're followed for 6 months, and those in the intervention arm also do an exit interview to understand their experience with the guide clinical trial navigator. So patients in both arms of the trial get referrals to patient navigation, social work, access to all of the patient supportive care services that are here. And we're really just testing in this early pilot trial whether the addition of that navigator and reimbursement then can influence whether people are more likely to enroll on a trial, and of those enrolled, whether they're more likely to complete the entire trial. So the outcomes that we're interested in are first just acceptability and feasibility. In this pilot trial, we want to know, does this work, right? Do people resonate with having a clinical trial navigator and working with the navigator during their clinical trial? How does it fit within the current workflow? But we want to know, does it increase trial enrollment, trial retention? We're measuring patient trust, health-related quality of life, resilience. We want to know whether we resolve those health-related social needs that we identify up front and understand the financial burden. And I showed you that we're also interested in how much all of this costs, because we want to build this in and make this a sustainable program going forward. And we think that by having people really work with a navigator, maybe they won't miss clinic visits later down the road, or end up in the emergency room, or experience other high cost kind of services. And so although there's an upfront investment by starting this program, we really think that we may be able to show that this is a sustainable long-term solution to help people enroll in clinical trials. So we're trying to address multi-level structural determinants of health. We're not saying that this is a problem at the individual patient level. We're trying to come at it from a systems and institutional level approach to screen all patients for clinical trials, provide navigation, and support patients with financial resources. Our goal, of course, is to increase access to clinical trials, to be able to support enrollment and retention. We don't want people just to get on the trial. We want them to stay on the trial and be able to participate in all of those activities. We want to develop a sustainable program. So I talked about how that upfront investment may be able to reduce downstream costs, and that's one of the things we're studying. So this is funded by the Andy Hill Care Fund, our Washington's cancer research endowment. And there are a whole bunch of people who are working on this, and I'm glad to have collaborators in prostate cancer and GU oncology. It's a lot of fun to learn how we can better support patients who are considering clinical trials as an option for their care. Thank you.
Thank you, Jean. So again, let us know if you need a card, and we can pass them around. Thank you very much for that talk. So a fantastic effort, something that we will learn from, and I think will improve clinical trial access and improve care for patients in our catchment area, which is Washington State plus, as I always like to say. All right. So next we have Dr. Pete Nelson, professor of medical oncology. Dr. Nelson, again, similar to Dr. Lynn, has a lot of titles. He's the new director of our precision oncology program here at Fred Hutch, one of our leaders of IPCR as well. And we're very fortunate to have him here today. Looking forward to the talk again with the different car analogies. Help me understand what is a very complex topic in a rapidly changing field. So thank you.
Thank you, Yaw, and there you go. So we're switching gears a bit here, and we'll talk about what we think about in terms of treatments for more advanced prostate cancer. So this will be this discussion outline. I'll give a little background and definition of really what we mean by advanced prostate cancer. Talk about really the major importance of subclassification. You heard a bit from Dr. Lynn about different Gleason grades. For advanced prostate cancer, it's critically important to determine what subtype of prostate cancer that is, and that's mostly using genetics and genomics to understand alterations in the DNA of those tumors, and I'll describe why that's critically important in terms of guiding treatment. And then we'll talk a little bit about new therapies that are really making major headway in treating advanced prostate cancer, and then talk about future directions. So just so we're all on the same page, when we talk about advanced prostate cancer, we're talking about metastatic prostate cancer. And that is prostate cancer that has left the prostate gland and gone to a distant place. Oftentimes that's the bone, but prostate cancer can go to other organs such as the liver and the lung, and certainly lymph nodes as well. So when you think about it like this, starts in the prostate, spreads to a distant place. We still call it prostate cancer, even if it goes to the bone or the liver or the lymph node, because we still call it by where it came from, by where it started. And once it's spread to one place, it's common for that place to then go to other places. So there's kind of a chain reaction, so to speak. When prostate cancer spreads, it almost always spreads to more than one place, which means usually we have to think about treatments that treat the entire body through many of these disseminated or places that it has spread. And that's where usually the medical oncologists get involved, because we give the types of treatments that affect prostate cancer wherever it might be in the body. Here's a typical bone scan. So you can see those very dark spots on the skeleton. That's an example of an individual where the prostate cancer has spread to multiple different places in the bone. The very first treatment for prostate cancer that really applied this idea of treating the entire body was using hormone therapy. So this was a Nobel Prize winning discovery in the 1950s that prostate cancer was extraordinarily sensitive to testosterone. So for advanced prostate cancer, our major initial treatment is suppressing testosterone, which results in the death of many of those tumor cells. Unfortunately, not all of those tumor cells, but you can get dramatic clinical responses as demonstrated by Dr. Huggins' Nobel laureate address, where he describes the really positive benefit of anti-cancer effect by simply suppressing testosterone. So here's the analogy. If you think about prostate cancer like a car, the engine driving that car or making it go is a little protein in the prostate cancer cell called the androgen receptor. So think of the AR, or androgen receptor, as a molecular engine. The gas keeping that engine on is testosterone. The exhaust from that engine is PSA. So when PSA is measurable in the blood, you know that engine is on. So the goal for this initial therapy is to turn that engine off. First step is getting rid of the gas. There's other approaches now that I'll briefly allude to later. There are medications that block the gas tank. And so we'll often double down on this pathway by giving multiple drugs, all designed with the goal to turn off this engine by eliminating androgens or testosterone. So the treatment for advanced prostate cancer, fortunately, has made major inroads in improving survival. So this graph shows the very first therapy. The bottom, the time will be time of an individual's life. So initial therapy is suppressing testosterone. Then it turned out we could add a chemotherapy drug. First chemotherapy drug shown to make men live longer is docetaxel. So that was a landmark discovery. The next was applying drugs called androgen receptor signaling inhibitors, or ARSI. That's kind of blocking the gas tank. Those drugs were also shown to make men live longer. The most recent approved therapy is a smart approach to target prostate cancer with radiation. It's a therapy called radium or Pluvicto, which targets a protein called PSMA on the surface of prostate cancer cells. And I'll show you a diagram of that in a minute. What happens every time we test the new therapy, we're usually testing it after all the preceding therapies have failed. So it's once a man has kind of run out of options. Once it's approved, showing that it improves survival, then we start using these therapies earlier. For example, is there a therapy that we tried late in a disease course that showed it make men live longer, had less side effects than the earlier therapies? So now we move it earlier to see if it would have benefit there. And that's exactly what's happened with these drugs that block the gas tank, these ARSI drugs. We now use them commonly before chemotherapy because chemotherapy, as you know, has side effects. Okay, so there's new therapies that have been developed that address these different subtypes of prostate cancer that I'll talk about now. So this is the idea for precision oncology or precision medicine, that we don't treat everyone the same way. And it's really about classification. Are there different makes and models? Are there different subtypes of prostate cancer that would benefit better from one type of therapy versus another? Because we know we're all different and our cancers are different as well. So we'd like to have a test that can be done on the tumor or on the blood that predicts behavior, that would predict you would respond better to this treatment versus another treatment. So it would specify what type of therapy you should have. And that's exactly what we have now. So this is a very complicated picture. Every column on this graph is a patient. Every row on this graph is a different part of your DNA. These are different genes that turned out to be also molecular engines that drive the cancer. So the main and the little colored boxes are whether that man, whether that cancer had an alteration in that molecular engine. So you can see there's a lot of variation. but there's also some consistency. So for example, that molecular engine we talked about, the androgen receptor, turns out that's altered in more than half of men with advanced prostate cancer. So it's a more common alteration as opposed to some of the others that are more rare. So think of it like this. I already told you there's an engine, the androgen receptor, a molecular engine. Turns out different prostate cancers have different engines, and we can't turn them off the same way. We need different drugs that block each of those different engines. So here's an example on the left. That's taking that big graph that I showed you and breaking it down into very specific targets. And on the right, under treatment, those are the specific treatments we have that address those particular targets, right? So here's an example of a response. This was a clinical trial of taking men where their biopsies showed one particular alteration in how their cancer repaired DNA. And then we gave a drug that was specific for that molecular change. So what you're seeing here is time on the bottom out to 21 months. And then on the top graph, it's the percentage of those individuals that have not yet progressed, so their cancer is responding. So the blue line shows a much greater response, a better outcome than the red line when those individuals got this particular drug called olaparib that targeted that pathway. So that's the DNA. That's the genome of those tumors. The big change now has been thinking beyond the genome and looking for other features or other characteristics of that tumor, and we call that the phenotype. So getting back to the car analogy, there are some prostate cancers that have the same engine, but the body types are different. The makes and models look different, and that's what we now target. We target the surface, the outside of that tumor cell. So here's an example on the left that's a prostate cancer. The little squiggly line is a target that's produced on the surface of that prostate cancer called PSMA. So these cell surface targets, the kind of body of the tumor, we can direct very specific therapies to, such as radiation or immune cells. And those are these examples, ADCs, BiTEs, and CAR T cell. So CAR T cells, almost finished here. This is a therapy that has revolutionized cancer care, particularly in leukemias. So leukemias, very difficult to treat some types of leukemia. There's a little cell surface beacon on some of these leukemia cells, and you can direct your immune system to go after those cancer cells and completely eradicate them. So for prostate cancer, we're opening our very first clinical study of what's called a CAR T cell. So you take some blood from a patient, you isolate the T cells. The T cells are the type of cell that directly kill a tumor cell. You engineer it to produce this, to recognize this protein STEAP1. This is our target on the outside of that tumor cell. You grow up millions of those T cells and infuse them back into the patient. They circulate around and they will attack and kill any prostate cancer cell that produces STEAP1 protein on the outside. So this has just been activated. We have yet to enroll our first patient. Hopefully the first one will enroll this month, and we'll see how effective this therapy originally developed for leukemia and lymphoma, we'll see how effective it is in prostate cancer. And then finally, I alluded to this earlier, this other molecular beacon, this target, PSMA, also on the surface of the tumor cell. We can use that to identify where the prostate cancer is by imaging using what's called a PET scan. And then we can also target any prostate cancer cell that has that little beacon with radiation therapy. And that's this newly approved therapy called Pluvicto, which delivers directly onto the tumor cell a dose of radiation, sparing other normal cells. So finally here, we've heard previously there are clear disparities in prostate cancer incidence and aggressiveness based on ancestry. The good news is all these different molecular features that I've just been talking about are pretty consistent across ancestry. So in terms of looking at the DNA in the tumor or these cell surface targets, it's pretty equivalent whether you're talking about men of African ancestry or Asian ancestry or Northern European. So we use the same tests to determine the best treatment for these different tumors. And then finally, it's been now shown that men with advanced prostate cancer, if you're of African ancestry, for using these medications that target that androgen receptor molecular engine, the outcomes are actually better in Black men compared to other races. And that's, again, this survival curve with Black men being the upper line compared to other Caucasian men. So if we're looking at survival, it's better. So very important to determine the molecular subtypes and then to treat accordingly. So summarize here, metastatic or advanced prostate cancer, when it spreads, unfortunately is still generally not curable. All these therapies have done a fantastic job in extending survival, and we're working now for improving therapies that will completely eradicate and hopefully cure these advanced prostate cancer. So the good news is these therapies can be effective for many, many years. These subtypes of prostate cancer respond differently to different therapies, and there's a lot of research ongoing here to really determine how do we find cancer spread early using those molecular imaging approaches like the PSMA PET scan, understanding why some prostate cancer remains silent for many, many years and then recurs 10, 20 years later. Determining how they spread and why it even goes to the bone, which we still don't honestly understand, and then developing these targeted therapies, the CAR T cells, the radioligand therapies, and other immune-based approaches to improve our overall outcomes. So I'll stop there and have time for questions later. Thanks.
Thank you, Dr. Nelson. I know we're covering a pretty broad set of topics and a lot of information. Again, this is a good time to raise your hand if you want one of those index cards, if you've already filled the ones that you have. All right, see some hands up. John or Liz, maybe we can pass those out, index cards out. Our last speaker is Dr. Ruth Etzioni. She's a professor of in the Public Health Sciences Division at Fred Hutch and the Department of Epidemiology at the University of Washington. Dr. Etzioni is one of the first people I met with here when I started as a fellow, and she's been a really important mentor for me. More importantly, she is internationally renowned for the work that she's done in the early detection of prostate cancer, and I think the work that she has helped lead is going to change in a positive way how we look at early detection and some upcoming guidelines that are really important. So thank you for being here today.
So much. Yes, we met soon after Dr. Nyame came, and shortly thereafter, we published a commentary in the Journal of the National Cancer Institute, and the title was Prostate Cancer Screening Guidelines for Black Men, Spotlight on an Empty Stage. Because despite the clear understanding of the increased risk in this population, all of the guidelines groups basically said, if you're in a high-risk population, for example, if you're a Black man, talk to your doctor about screening. And they never actually gave a guideline. And so the first part of what I'll show you, and I really will do just a quick update, and I won't talk very much about the work that we're currently doing, but Dr. Nyame mentioned that our group is working with the national groups that issue guidelines, like the American Cancer Society, who are updating their guidelines, because it's very difficult when you want to make a guideline for the population. First of all, you recognize that one size does not fit all. Second, you have many studies, but they often disagree. We had 2 large screening trials of prostate cancer. They disagreed. Lots of studies disagree because they're done differently. They're done in different populations. They don't apply to the question necessarily that you want to ask. There might be a 10-year study, but you want to talk about screening men for 30 years. So how are you supposed to take all of that data and figure out what the evidence is and the answer to the question is? And that's what our group does. And we've been doing it for a while, and we are now working with those large national groups that will be publishing guidelines starting in about a year. The American Cancer Society will have published their updated guidelines. So what I'm gratified to see, though, and I want to show you in the beginning of my quick update here, is that guidelines panels are now starting to be more explicit about how Black men should address prostate cancer screening. So this is actually was a guideline that was co-led by Dr. Lin, and I was on the panel from the American Urology Association, was published last year. And there's a very explicit statement about beginning at actually an earlier age than population screening for Black men. And then just earlier this year, Dr. Nyame was on this panel from the Prostate Cancer Foundation that published the first screening guideline totally devoted to Black men and came up with a very similar recommendation for starting earlier, based in part on some of our work. But I want to focus on now the last statement of this guideline, which says, or of their conclusions, which talks about personalized prostate cancer surveillance and or treatment can prevent potential harms from overdiagnosis. And I want to just unpack that. I spoke to a reporter a few days ago, and she said to me, how do we make people understand, she was talking about breast cancer, that there is such a thing as overdiagnosis, that that there are cancers that screening detects that you might not have to treat. That because everyone, for decades, we've felt that, if we're doing screening, we find cancer early, we treat it. And overdiagnosis, just to make sure we're all on the same page, is was when screening diagnoses a cancer, and you don't need to treat it because without screening, you wouldn't have known you had it. You would have died of something else. And this is particularly, we actually realized this was a problem in prostate cancer more than 10 years before people started talking about it in breast cancer. And we know that it exists, first of all, because old autopsy studies showed very high rates of undiagnosed prostate cancer in older men. And then when we started screening in the US population, here's the incidence of prostate cancer. And that big peak is right after we started screening in the United States, and the incidence of prostate cancer basically doubled. And it happens because cancer exists. In the case of prostate cancer, can exist for years before you know that you have it. Then you screen in that time, you'll find it. If your disease is slow growing, is hanging out for a long time, these are the men that we're trying to target in active surveillance, you'll be more likely to be an overdiagnosed case. And majority of those cases have signs that they're slow growing because they're grade group 1. But also, if patients are older or sicker and they have prostate cancer that exists, and maybe it won't hang out for such a long time, but they have a competing risk of dying of something else, then finding that cancer may actually not be a good thing for them, because then they may feel compelled to treat it when they really want to be focusing on other conditions, and it won't help them. So how much overdiagnosis exists? This is a question that's been around for a long time. It's very hard to know because the only way to know is not to treat people, and we treat most people, right? So we have to do some detective work with the data, and here's a paper that we published in collaboration with faculty at the university, where we try to do a personalized risk of overdiagnosis. And in this paper, we actually also looked at comorbidity. This is just overall. And just want to show you the graph to show you overdiagnosis risk among low-grade cases by age and PSA. And this is for low grade. We did it for different grades. So in low-grade men with a relatively low PSA at an older age, the risk of overdiagnosis is over 50%. More than half of men diagnosed did not need to be diagnosed and should not be treated. And this, of course, has led to this conclusion that we should be doing personalized prostate cancer surveillance, screening, and treatment. So what does that mean? Personalized means that depending on a man's PSA, he may have different pathways to diagnosis and treatment. There is no one size fits all. And so new prostate cancer screening guidelines are geared towards not trying to diagnose those grade group ones, but if they're diagnosed, they're not trying to treat them. And not recalling the order for today, I put some slides about active surveillance at the end, all of Dr. Lin's studies that he explained so well, so I can take a little more time on the treatment part, on the screening part, and not spend so much time on the treatment part. So we have new tools for not diagnosing, for doing better and not even diagnosing those low-grade cancers. And so the two that I'll talk about are biomarkers and MRI. And these are in guidelines. There are different guidelines. These are from the National Comprehensive Cancer Network. And they suggest that clinicians use these tools if a PSA is elevated so as not to send a man directly to biopsy, so as not to diagnose these insignificant cancers and also to avoid false positives, unnecessary biopsies. What do we mean by biomarkers? Well, that changes from day to day. We already have more than a half a dozen biomarkers developed by different researchers, and the list keeps growing. How good are the biomarkers? Well, first of all, I've got a list over here. It's not even complete today. There's even new ones today, but they're blood or urine biomarkers. So this means after a positive, you have an elevated PSA, particularly if it's moderately elevated and kind of in a gray zone, you may have an option. This may be an option before going to a biopsy. So the idea is that you do the biomarker test, and if it's negative, the idea would be that ideally, you would be able to be confident that you don't have a significant prostate cancer. So how well do they work? There are many, many studies. Overall, they reduce the risk of an unnecessary biopsy by about 1/3. They capture, in doing so, they do capture most of the clinically significant cancers, but they don't capture them all. So they reduce the risk of an unnecessary biopsy by quite a lot, and they reduce the chance that you'll find a clinically significant cancer by a little bit, up to 10%. So when you talk to someone about whether you should try this biomarker, it depends who you talk to. The people who are producing the biomarkers think that this is a great equation, but a patient may not think so. But you can't know unless you know to ask. And one thing that we don't know is that we don't really know how many men know about these biomarkers and how many of them and how they're being used. When I talk about MRI next, I'll show you a recent study of how MRI is being used. But we actually don't know. I think that these biomarkers are available differentially in different parts of the country. Different people know about different ones. And so overall, this is essentially the outcome of using these markers. They are very good at limiting false positives and overdiagnoses and detection of low-grade cancers. But there's a small chance that they'll miss a higher grade cancer. If you are in a regular screening program, there's a good chance that you'll find that cancer probably at your next screening occasion. It's not a clear, I'd say it's not a clear yes or no. I think for different people, there may be a different preference. From a population perspective, I think they're beneficial to limit overdiagnosis, particularly in older men who have very high rates of overdiagnosis. What about MRI? I feel like a bit of an imposter showing you these slides because Dr. Lin and Dr. Nelson can tell you a lot more about these imaging scans because they see them all the time. But just to, with an educational purpose here, what about MRI? So traditional biopsies are ultrasound guided. The ultrasound helps to locate where the prostate is, and then you can then biopsy the prostate, and then the typical what's called systematic biopsy obtains 12 cores of tissue throughout the prostate, 12 needles. But it's kind of random in a way. Like how, but this is how I'm going to if you have questions specifically about this, I'm going to direct you to them, but this is the historic way of doing it. And so obviously having an imaging test that could actually locate the cancer itself, and particularly the clinically significant part, was just a holy grail. And lots of studies of MRI, because it has very accurate anatomically suggested and indicated that it would be able to see these small areas of significant prostate cancer. And so the role is also, as a secondary test initially, was to actually see if you have high-grade cancer and or Gleason group 2+, and really similar to the biomarkers. If the test is negative, being confident that you don't have a clinically significant cancer. If it's positive, going on to biopsy. But then it opened the door to a choice for biopsy. Now, when you go for your biopsy, should you see a small area, maybe you should just biopsy that area. That's called targeted biopsy. Or do you still go for a systematic biopsy? Kind of sounds like a no-brainer, except that in a study where they did both, it's a little bit of a busy table, but I'm just going to direct your attention to the bottom where they did both in a fair number of patients. Neither the targeted nor the systematic found all the high-grade cancers. The targeted found 87% of the high-grade cancers. That's in green. There were 918 altogether. So the targeted biopsy found 87% of them. The systematic biopsy found 71% of them. And again, I don't know how frequent this is now, but I think that in a lot of times now, patients are getting both the systematic plus the small areas that look like they might be systematic plus targeted. So how does that perform relative to just targeted? Can we actually omit the systematic part? Certainly the targeted is better. Could we omit the systematic part? Well, it will miss some of these high-grade cancers, but it will also reduce the detection of low-grade cancers. So literally just last week, this study came out in the New England Journal where they actually compared the both approach with just the targeted approach. And it wasn't just one time. They actually did it within a program and they got 4 years of data and they found what they expected. All men who got MRI, they all got MRI, but then they were randomized to get both biopsies, systematic and targeted versus only targeted. And targeted biopsy reduced the insignificant cancers by 60%. Very effective in that way. It reduced significant cancers detected by a small amount. You can see here on the bottom, it detected 1.8% of men were detected with a clinically significant cancer versus 2.1% on the both approach. So they're very focused on the 60% reduction of the insignificant cancers, but they did miss a few significant cancers. Again, they were in a program, so men are coming back every 2 years. Most men are coming back every 2 years. So this is a very recent finding. So MRI seems to be, and I think there's a general consensus and the guidelines are recommending it, but who's getting it? Well, you can see on the left that usage has increased dramatically, but is very different. This is the most recent years. It only goes to 2022. If that curve's going up so fast, it's quite a bit higher by now. But you can see that, certain states in the light blue are getting considerably less. And thanks to Dan, I therefore do not need to talk about the personalized approach to treatment. This is from their paper. But what Dan didn't mention was that they also published a paper about safety in Black men, where they found, they didn't have huge numbers, but they found very little, they found no difference in the gray group 2 risk among Black men on active surveillance versus their white men in their study. So concluded that it was not that Black men were not at a higher risk of progressing to a grade group 2 than white men if they were in a study in which they were all being monitored and surveilled and all undergoing the same treatment and protocol. Because there were other studies that showed that population studies that suggested that Black men had worse outcomes under active surveillance, but they were not as well monitored and not as compliant. They didn't actually have the data on how men were being managed. But in this study, everyone got the same. And they concluded that, this is actually from an interview with Lisa Newcomb with Fred Hutch News Service, that you got to stick with the program. If you stick with the program, it is safe. So that's really my last point here. Black men have a higher risk of prostate cancer at every age. This means that they have a higher chance of benefiting. If you come to screening, among the men who come to screening, they have a higher chance of benefiting, all other things being equal. You cannot benefit from screening if you do not get biopsied and treated appropriately, not just treated at the time of diagnosis, but also later on. We talked about survivorship, even later on. And so, but Black men then also, because they have more cancer, they also have more chance of overdiagnosis, men who are coming to screening. So this makes these personalized approaches even more appealing to Black men. And that was what is so great about this collaborative, about BACPAC, is that it provides a way to get this word out so that Black men everywhere know their options and know what to ask. If they're told you need a biopsy, what kind of biopsy? Are we talking targeted? Are we talking systematic? Are we talking both? What is best for me? Thank you.
Thank you so much, Ruth. We're going to turn these chairs around. You guys didn't want to sit in the front row, so you made our jobs easy. And we'll bring our speakers up. If you have cards, please let us know and we'll come collect them. If you go to the IPCR meeting, what I'm doing right now, Dr. Nelson does, I've not really appreciated how challenging it is to be the MC of questions. So, because there are a lot of good ones here. All right. So one of the first questions that was asked just says hot flashes, and I'm going to go to you, Dr. Nelson. Hot flashes are a common side effect of hormone blockage or castration. So let us know what options exist for patients to deal with them.
Right. So hopefully that's on. Hot flashes. It's actually quite remarkable when I see men in the clinic that are getting testosterone suppression. That's usually the cause of the hot flash, very similar to when women at menopause. So you'll get no sympathy at all from your wives because they're dealing with the same thing. But the remarkable aspect is it varies so much from man to man, right? I've got some patients that have never a single hot flash, and others that have 20 a day, wakes them up 4 times a night, et cetera. There are a couple medications that can help with that. One is a type of an antidepressant that at very low doses can kind of take the edge off hot flashes, called Effexor. Another medication that works extremely well is a progesterone, another type of hormone. So we give it as an injection at the time when you're getting the hormone therapy, and that can, in many men, completely abrogate the hot flashes. Another is actually a hormone estrogen. So you can have a little patch that can help as well. Unfortunately, there's none of these other medicines that don't have other potential side effects. So you kind of have to weigh that, and it doesn't work for everyone. So the key is to work with your oncologist or whoever is providing the hormone medication and try one thing. If it doesn't work, then you try the next one, et cetera. But it's a really tough problem. And I will tell you, we don't still even understand why they happen. Yeah.
All right, we have a card over there. Thank you for that answer. And it's a shared common symptom that we hear a lot about. And we'll try to get you some of those answers.
sorry, but that was just, so it's like salmon oil. Oh yeah. So my, cause on my way here, I was singing, I'm having a hot flash, like seeing the wheels on the bus, and, it doesn't really, I might be even having one right now. I'm not sure, but it doesn't really affect me too badly, but she was suggesting salmon oil tablets, taking 2 of those a day. Just, just a
Salmon
suggestion.
oil tablets from naturopath. Thank you, Doug, for sharing that. So the next question I have is towards our leaders of our cancer center, because these are 2 very good ones. And I think everyone on the panel can answer. So how does participating in a clinical trial benefit the patient with his or her treatment? And what are the most important trials that are going on in prostate cancer at the Fred Hutch right now? What are you recruiting for? Those are big ones.
Yeah, I mean, I'll start with the first one, which is about clinical trials in general. I think that we lead a big platform of clinical trials. They're very balanced. In other words, we run very few like straight placebo. So there's not a lot of trials we run here at the center that patients are getting nothing. In fact, there are those trials out there. We tend not to. All trials have to go through a board that looks at safety from a patient perspective and so forth. What is the benefit? We've seen in general patients on clinical trials, to kind of put it bluntly, do a little bit better than what's expected later, in part because they're getting very close calendar follow-up. And I think Dr. Etzioni referred to this. Those patients in the past study, which I was telling you about, have a study calendar. I mean, they're like month 24, you do this, month 36, you do that. I mean, it's very regimented. Our study coordinator looks and says, oh, the patient is due, it gets done. In the community settings, let's say out of a clinical trial, a patient might, oh, at month 36, I'm fine, I don't need that, which I normally might get. And so they're not on a really regimented study plan. And so oftentimes, just in the course of clinical care, anywhere, not just in the community, patients aren't being followed as closely. They might not get that scan exactly on time. They might not get the blood draw exactly on time. And we know that patients on clinical trials are held to that by the clinical trial, and they do end up getting a little bit better outcomes and results because of that. So that's about clinical trials. Maybe someone else wants to talk about trials.
I'll just make one comment that there's different types of trials. So it's important to recognize there's different phases. Phase 1, first time a medication has ever been used in an individual. So it's really about safety, but there's clear evidence of efficacy as well. Remember, every drug that ends up getting approved went through a phase 1, 2, 3, generally clinical trials. So as a participant, you get the opportunity to early on potentially have the benefit of that drug that ends up showing prolonged survival, for example. Phase 2 is really looking for, is there efficacy? And then phase 3 is it better than what's already up? Right. So it's usually a head-to-head comparison about whatever the standard of care is. So Fred Hutch has websites showing active clinical trials. There's also a big one at the NIH that's called clinicaltrials.gov that shows you every clinical trial in the US and sometimes the world. And there's a patient-facing version as well as one for the providers or the physician. So you can go on and do search terms like prostate cancer and metastases, and you'll find the trials.
I'll just add that I think that we here, as far as clinical trials that are open specifically, we do have this sort of forte in understanding what Dr. Nelson was saying, which is sort of your genetic blueprint. So the genetic blueprint of the patient, sequencing their DNA, understanding their underlying risk that they inherited when they were born. It wasn't anything they did. It was some genetic variant. And the big one that we're looking at right now is related variants to the BRCA family. So you might have heard people say BRCA family for breast cancer is associated with prostate cancer. And I had a slide, I didn't have time, but we're looking at individuals that have those variants, whether they have prostate cancer or not. And we have clinical trials for that group of individuals. And there are really great examples of trials of individuals who have breast cancer with those variants showing remarkable results to personalized drugs. So we're translating that now to prostate cancer.
I'll just add, we had our patient research summit. So the folks that are working with us in BACPAC in September. And one of the things that came out of that was that, going to the NIH website, for instance, and looking at the trials and the definitions and all of that can be really hard to sift through. So one of the things we are charging BACPAC with as a deliverable is to maybe distill down the trials into more simple language and hosting out on our website so people can be up to date on what we're offering and what it means. And we'll use the BACPAC network to make sure that what we develop is understandable, which we've had good success with. So I'm going to switch gears. Dr. Hehemann, what are the side effects of minimally invasive surgery for prostate cancer, specifically on leakage and incontinence?
Yeah, so as I sort of showed that table in my talk, in terms of leakage, that is one of the side effects that men can experience after robotic surgery for prostate cancer, so radical prostatectomy. The majority of men do recover dryness or continence by 1 year, but there are a small proportion of men who don't. And so some of the things that we have as tools for us are things that you can wear day to day, like protective pads, protective sort of devices that squeeze down on the urethra to prevent the leakage. And also there are many surgeries that we have, 2 that are very well established and then more that are sort of like I mentioned in the pipeline, that are really promising, that offer truly some of the most life-changing things that I do for men who have leakage, because it impacts so much of men's quality of life, from the emotional state to confidence to just, being sort of paranoid to go out with friends. And it can be extremely impactful on men and their partners. And fixing it is, again, like I said, I help people create families. My job is often very joyful, and that's really one of the most impactful things that I do. So, but I would say that it's very unknown in the community that these tools are available to prostate cancer survivors. So I have had, I had a patient yesterday who's been leaking for over 6 years and was never told that there are options for him. I had a patient that I did surgery for who had been leaking for 9 or 10 years, and he had also never been told, because surgeons who do these types of surgeries are a little more rare within urology. And so they're just not talked about. And for whatever reasons, for probably many reasons, they're not talked about with patients. And it's a real unfortunate. So now everyone here is aware, and you can spread the word to your friends. And even if they haven't had prostate cancer treatment, but have leakage or, sexual issues from other reasons, there are so many tools, and not anything that you need to be ashamed of. There are specialists who talk about this all the time and are super comfortable and are just hoping to make you comfortable and better.
Thank you. I'm going to switch gears now to Dr. Etzioni, and I will just say there are some questions that I'll address maybe in our closing remarks because they have to do with health equity, and I feel like those are things that I should answer, although some of those are coming your way, just so you guys are aware. This is a great question because it's one that we debate and talk about all the time. This says, it starts with PSA testing can produce false positives. Right. And so the question really, the heart of the question is PSA effective? How should we weigh the efficacy of PSA in making a decision about screening? And I think the answer is simple, but we know that it is very controversial.
Well, I think that every screening test has false positives. So that's the first thing. Every screening test has false positives. Every screening test has false negatives, because no screening test is perfect. Look at COVID testing. That had a heck of a lot of false negatives. People get their negative COVID test and go out to a party and then have symptoms the next day. So what is difficult is that not every the information about false positives, false negatives, false.
Try this one.
false positives, and that's, it's not just front and center on the test. Like, where do you find that, right? But every time you have a test, it actually is a fine thing to say, what is the false positive rate of this test? And hopefully the person that's giving you the test knows that. May vary from person to person, may not be the same for everyone. So now then, so it just is a fact of life. So the thing about false positives is that knowing that it could be, the first thing is it tells you how to handle getting a positive test. So if there's a fair risk of a false positive result and your test comes back positive, don't panic. Could be a false positive, right? And then the second thing is being able to then do something that can tell you whether it is falsely positive, that hopefully is not too painful, like a biopsy, right? And so at this point, I think we're doing better on that front. I think we're really doing better than we've been ever have done in prostate cancer screening to be able to go to that next step. And so with that, I think having the knowledge of false positives, knowing what you can do, knowing that there is something that you can do, and then being able to access that. Because MRI is something that I think is quite effective, but not everyone can access that. It is not cheap in this country. It is, even if you're insured, it's not uncommon to be denied. So maybe that's getting less uncommon, but then the last part of it, so then is what's the efficacy? So the efficacy is kind of on the flip side. The efficacy is on the side of benefit, and then the false positive is on the side of harms. So screening becomes a harm benefit calculation. And if there are ways to reduce the harms, we know that it's beneficial. So we know now I can say that there is a consensus, except in the UK, that it's beneficial, because the UK has not been advocating screening for prostate cancer. But it's not the same thing. Efficacy and false positives are not the same thing. False positives on the side of the scale of harms. We have ways of dealing with that. We want to know the risk of that. And then there's the benefit. And we want to know what that is too, right? Yeah.
Thank you. And I think that the way that harm benefit balance is being evaluated by policymakers is changing, in part to evidence like what Dr. Lin has helped produce and presented, right? That we can do less harm. So in line with that, there have been several questions on what is really low risk cancer. Everyone in the audience has heard multiple terms that we clinicians use that are all, some of them are terrible, but you've heard insignificant cancer, you've heard low risk cancer, you've had favorable risk cancer. I'm sure we've used all three terms because we use all three terms. What are those cancers like clinically, Dr. Lin, and what would you think about someone that didn't meet that criteria considering monitoring or surveillance?
Yeah. So a couple real quick comment on what I've been thinking a lot about what Dr. Etzioni was saying, and about false positive, about testing, and how good is PSA. I mean, I think that it's here to stay. It's not going to go anywhere. And there is a positive test, and then there's a positive test. I mean, I think that the older I get, I guess, and seeing patients, and in the guidelines we say you never should probably use PSA in a vacuum. And I tell, in other words, there's symptoms, there's age, there's how high the PSA is, or what the DRE is, how big the prostate is. So there is a neural network I have in my head. So if someone comes with a PSA of 4.1, that's positive. Someone comes up with a PSA of 14.1, that's pretty positive. And I think those are different. All right. If somebody has prostatitis symptoms and there's a reason, a big prostate, and they have a mildly elevated PSA, that's different from the same exact PSA number in a man with a tiny little prostate that has no symptoms. Okay. So there are reasons, and I tell everybody, the only really three major reasons for a high PSA is a big prostate, which is the most common, prostate cancer, or prostate infection or prostatitis. I mean, that's kind of like the three reasons. And it's in totality. So unfortunately, I think those that are the governing bodies of medicine are just looking at PSA alone. I mean, oh, PSA, yes or no, and that is the simplest thing for most primary care practices. But for us, it goes beyond just a PSA test. So with regards to low risk, to keep it simple, I think most of us think lower risk is a low Gleason, which is a 3+3, or maybe a little bit of 3+4 with a PSA less than 10 and a normal rectal examination. I mean, I think that's the easiest answer. Yeah, I mean, I think that might be the easiest way to look at it. For years and years, it used to be just 3+3, Gleason 6, #1 cancer, nothing more. But now we're realizing that maybe a little bit of the 3+4, and again, there's a little bit in it, and I say it's just math, how much 4? How much 4 is it? And there are nuances. And then even the 3+3s, there are some bad actors. So we're trying to dissect all that out. But to be real simple about it, it's Gleason 6 and a PSA less than 10. That's what most people think.
Yeah. There was a question, for a 57-year-old with Gleason 6, tumor less than 1 millimeter, is active surveillance recommended or treatment? Absolutely active surveillance. We have colleagues in the country that are wanting to call this type of presentation a non-cancer diagnosis now. I personally don't think that that's the right answer. And certainly, I think if we're going to have that kind of a conversation, we should be involving all of you. And we have some research ideas around how to have that kind of a conversation, because it's a really big decision that would change, clinical care and outcomes moving forward. Just to stay on the active surveillance topic, because we had quite a few questions. What are some triggers for treatment? How do you determine someone has more aggressive cancer when they're on surveillance? And I think the question came both in the setting of initially presenting with really low risk and with a favorable medium risk, if you will.
Yeah, if they initially present as #6 cancer, again, it used to be anything more than that. So even 3+4 a little bit. I think that's changed a little bit. Now it's like if it's a lot more 3+4, there are those patients that come in with that 1 core of Gleason 6, and then the next year they have 2 cores, and 3 years later they have 5 cores, and their PSA is creeping up. And I think it's kind of an inevitability of getting higher volume cancer, and we worry about that. So then the major trigger, not only in my group, but at Hopkins and Toronto, and you see all the centers around the world, is any increase in grade is the major trigger. Or a PSA getting up over 10 is another trigger, but usually it's a grade increase.
Right, thank you. So the next question is for Jean. The question says, when outreach to community of colors occur, it's most effective when research, clinical, or staff reflect the folks being reached in that community. And so I think there's a great opportunity to maybe highlight some of the things OCOE supports to address that initiative. And then if anyone on the panel, we have some leaders in our program, what are you thinking about making the workforce reflect the communities you're trying to reach?
Yeah, I think so within the Office of Community Outreach and Engagement, that's something that we talk about all the time. And there have been kind of an evolving set of new initiatives and programs to really think about how do we include community voices and then have people within our office who are really out in community doing the work and understanding where that comes from. So I think we have community health educators who are our kind of people who are out meeting with community-based organizations and partners and bringing together that sort of bi-directional communication that needs to happen so that research at the Hutch really reflects the needs and interests of people in the community. And so we have community health educators who specialize in different population subgroups within Washington State, including a Black and African descent community health educator who I know Dr. Nyame kind of works with to then build relationships. We also have patient navigators within the Fred Hutch who are like culturally and linguistically concordant with patients and work to make sure that there are also people who are reflected in, like when you walk in the door, you're going to meet with a patient navigator who is from the community ideally. So I think that, there are a lot of kind of things going on to recognize that. And then within Fred Hutch, there's also the science and education partnerships that are really talking about how we can diversify the workforce and make sure that that is also part of kind of understanding how to bring community into Fred Hutch as well.
I think this is a point of focus for the School of Medicine, Fred Hutch. I honestly, seeing what the landscape looks like nationally, I think we are leading in a lot of ways and trying to increase the diversity of our workforce to meet all the people that we take care of. And that's not just Black communities, but that's Latino communities, Indigenous populations. So it is a really exciting time to be here as we continue to work towards more equity in cancer care. Please.
An article that I had read indicated that if you want to get people of color, particularly Black men, in to have screening and particular areas around the prostate, that they need to see Black men who are there. And the interest that I have is, how is the institution changing to reflect that? So that when I show up, I mean, I fired my first urologist because he didn't get it, quote unquote. And it was Ben Young who introduced me to Dr. Nyame, and it made a significant difference in the way I began to see my own personal health. So my question is around, how is the institution, and I put that in quotes, making an effect to change who people see when they come in for treatment and who they talk to in the community?
I mean, I'm happy to answer, but I think maybe Dr. Nelson and Dr. Lynn both are in really significant leadership roles in the institution.
Yeah, I could just make two comments that might address this in part, and then certainly other input as well. In terms of like who you actually see, so I'll give you one example. It's even before who you see. We have a new initiative to try to encourage participation in research across all of the patients seen at Fred Hutch and the University of Washington. And this effort is called Take Part Northwest. And it will be presented initially through somebody's MyChart, through their electronic medical record, working on other methods as well. Part of the introduction is a interactive video with members of our community that want to participate in this research effort to improve health. And that effort was really driven by a community advisory board that we assembled to reflect the diversity of our community. So we have had fantastic dialogue with this group. They helped us put together this consenting process and video that encourages individuals to participate and explains why and how it'll go back and improve the health of the communities where people live and reside. So that's even before you're a patient. And so this entree into the healthcare system is explicitly designed to be as diverse as possible. The second aspect is, so you're exactly right, Fred Hutch, both on the clinical side as well as the research, faculty members here are clearly very skewed. We don't have a lot of representation from minority groups. I guess it was about 3 years ago, we explicitly had a hire that was called a cluster hire to find individuals fantastic scientists around the country that were from underrepresented groups in science. And we recruited, I think it was 6 or 7 faculty members all at once, 1 year. We're having another cluster hire next year that will do the same thing. And once we can start building a group, because one of the challenges for recruiting scientists here from these underrepresented groups, they don't have a lot of peers and role models here, right? So we need to start building a community. And so this cluster hire was effort number 1. For each scientist we bring, we provide a fantastic startup package to launch their career. Costs around $2 to $3 million. So it was a big investment for that first 6. And the center is committed to doing that again next year. So that addresses more the scientific part, less the clinical part. And maybe Dr. Nyame or Lynn or others have ideas of what's happening on the clinical side.
Yeah, I think so one of the roles I hold in our department is the associate program director of our residency. So these are the trainees. This is where Dr. Nyame and I met before residency. So these are folks coming out of medical school doing their urology training. And we know that Black and African American doctors are have low representation in urology in general, so quite low. Women are increasing. We're seeing some increases in diversity in urology, but it really starts with recruiting medical students into urology. And so that's part of my role as the associate program director with Dr. Lynn and our other colleague, Dr. Hagedorn, is to try to create a program of recruitment of the best and brightest and most diverse residents. And we've been successful in that effort in the past few years. And it's an ongoing effort. I think it, like Dr. Nelson said, it does take seeing someone on faculty to say, I'm going to be comfortable here. I'm going to be well-trained here. I'm going to have a mentor that looks like me. And so it also takes, hiring diverse faculty so that we can then recruit diverse residents. And so this is something that certainly is top of mind in our program as the residency program. I also have a role in leadership of our fellowship of men's health, and also is important for us in that way as well. There are very few women in men's health, and so I like to think that I, stand as a role model for women coming into the field of urology and men's health. And it takes effort and presence and intention.
A great point, Donnie. I'll also add, and again, I said I think we lead in this space, right? So when we hire, faculty have to have a diversity, equity, inclusion statement, and it can't be soft. People really want to see how you want to address equity and diversity. In 2020, we started a virtual mentorship program for students that didn't have formal departments of urology, right? Because your success of getting into urology, which is a very competitive training field, depends on your mentorship team, right? So, if you go to the right medical school, you have a better shot at getting in. So we wanted to create an environment where students who were interested but didn't have that kind of access could come through. We've had 5 students of color, Black medical students that we've supported from those types of programs. So far, we're 4 for 4 in getting them into residency programs, which is hard to do. So I think we're doing our part, and it's a departmental effort. It's an institutional effort, and it's going to take time, unfortunately, because it's a pipeline issue.
I just want to ask a question.
Yes, ma'am.
I'm in the mental health field, and in behavioral health, they have people called peer support specialists. And so there are people who are in recovery that come alongside new patients that come in the system. Has there been any conversation about that with Black men who have gone through treatment process to come alongside a new patient?
Yeah, great question. So this is something BACPAC is really interested in. The first bit of work we did as a group in BACPAC was just getting a sense of what the priorities were for addressing prostate cancer issues among Black patients. And it's very, very clear that social support and peer support and navigation are all packaged as something that's needed. We put in a $2 million grant to the Department of Defense to build a social support program at the time of diagnosis to help navigate all of the different components of making a decision about treatment. And we would like to do that by training peers to be the support network as navigators. We have John Masembe here. Wave your hand, John. John is a patient navigator at Fred Hutch. He's going to help us build this type of program. And we're due to put in a grant on Monday to the American Cancer Society, a $4 million grant for a cancer center of health equity research. And one of the projects is going to be led by John Gore, who I can confirm is not a robot, will be peer support in the survivorship space. So we're really interested in this particular topic. There are some, so if you're looking for that now, Zero has a network of peer support groups and a program called Mentor. So you can find some things existing now, but what we'd like to do is really take that existing network and improve it, formalize it, make it something that can be scaled up so it's more accessible. So it's too many questions to cover. It's lunchtime, and I figure like I'm between you and your meals. If your questions didn't get answered, hopefully our speakers will be around for some one-on-one. And as far as logistics of lunch, I'm looking at Ritu because I don't know, but she's pointing over there, so it's in the back of the room. So help yourselves, please. All right. And thank you to everyone for a fantastic set of talks on updates in prostate cancer care and health equity. Wow.
Testing.
Seen Victor? Yeah. We're down a panelist, but we'll find him.
Yeah, I just have one request. No questions from Donna.
I'm gonna have to separate you two.
No questions. No questions from all the black folks.
Leaving that one alone. All right. Hopefully Victor joins us. Oh, there he is. Victor.
There we go.
Do we have a third microphone? Right there. Why don't you take this one? All right.
What's your
Huh? Oh,
Oh, so let me put that up. I had to rush back. I was like, oh yeah, I'm coming.
rush.
All right. So our last session for today is going to be this panel. We called it the patient panel, but I want to just clarify that Victor is more of a community health advocate. And he's not a prostate cancer survivor, but as I said in the very beginning, when we are OGs for BACPAC, this was one of the guys with no reason to, right? Unprompted, didn't know me from anybody else on the planet, showed up, every other week for meetings where we were talking about prostate cancer care. One thing I'll say about Victor was it didn't take very long to know how much he cared about his community, about healthy living. And for me personally, my ulterior motive was to get a personal trainer so I could look buff and jacked. It didn't work out for me. He's too busy training NFL players and whatnot, but we're lucky to have continued this relationship. And I think his perspective is an important one, right? Because we talk about getting the word out and getting younger people to consider PSA testing. So with that big intro, our panel today is Victor Tolbert, now from Dallas, Texas. But when I met him, he was down here in Kent, Washington. We have Kojo Ward, who's also here in the Seattle region. Burien, I believe, is where he lives. Des Moines. Ah, so close. So close. Listen, this is progress for me. As you know, I'm from Oklahoma and I had a hard time knowing whether Puyallup was north or south from Seattle. So I'm progressing. And then we got Ken Hutchison, who is from the Bay Area, but has had and spent time here in the Seattle region. So I'm going to start with you, Ken. Can you just tell us a little bit about yourself and your who you are, where you're from, and what your connection to BACPAC has been?
My name is Ken Hutchinson. I lived most of my adult life in Seattle, Washington. I spend most of my time now in Bay Area, Berkeley specifically. My connection to BACPAC, I participate in a lot of the in-person sessions. I really get a lot of energy from being together with the guys and the ladies too, the doctors. BACPAC has been a realization of a dream for me. I was treated in 2015 and started attending the IPCR conferences. Ruth would be up there talking about her numbers and Black men, and it just energized me. And then when Yaw came along and BACPAC came to fruition, it was a blessing.
Thank you, Ken. I'm going to ask you to tell us a little bit about your personal connection to prostate cancer, and how does that relate to BACPAC as you described it as a blessing to you?
So I was diagnosed in early 2014, went in for a routine physical, and I was with Kaiser, and the PSA was part of that panel. I didn't have to request it. And my primary care physician, who I love dearly, said, Ken, no, number's a little high. I'd like to refer you to a urologist. That was the beginning of my journey. Had the follow-up biopsy, had low Gleason 6, so low risk. So I went on active surveillance for a year. After my second biopsy, I had more cores involved, and I went from 3.3 to a little 3.4, and that's when I decided to do external beam radiation 8 weeks. What I didn't know at the time, well, my team was pretty good. They explained, Black men have a higher risk. It can often be more aggressive. So I knew a little bit, but it wasn't until I started attending the IPCR and Ruth, and then with BACPAC, I've learned so much about how it impacts our community. So it's not just my story, it's our story. And one of the things I wanted to do was get the word out and what can I do, but now it's what can we do? And that's what's so important to me, the community.
Thank you. Hard to follow that up, honestly, because I think the community I think it's hard to put into words what it's like to look across the room and see all of you guys who know one another are working together, in community, right? And so thank you for sharing that and phrasing it the way that you did. Kojo, asked you similar questions. Tell us a little bit about yourself and your connection to BACPAC as it relates to you as a prostate cancer survivor.
Okay. Good afternoon, everyone. I think it's afternoon. My name is Kojo Ward. I was born in Ghana, born and raised in Ghana. And then I moved up here when I was a teenager on the East Coast, New York area, went to Maryland, Morgan State University. And after that, I moved out west to Seattle. Currently, I live in Des Moines. My connection to BACPAC, well, I was diagnosed in the fall of 2021, and I had prostatectomy in January of 2022. And early this year, I went through a secondary course of treatment, which was radiation, and I just finished that in June of this year. So well, before that, my father was diagnosed with, prostate cancer. And unfortunately, he passed, 6 months after he was diagnosed. So before he passed away, I had a chance to go visit him. And while I visited him in the hospital, one of the things that he said to me was that, hey, if you don't learn anything from me, please make sure that you tell your other siblings to always, um, check for your PSA, make sure that you go for your routine exams, because I did not, and unfortunately, this this is this is this this is what it's landed me, and unfortunately, after my last visit, when I left his hospital, he passed away about a month after that. And so it really stuck with me. But then back then I was in my early 30s. So I'm thinking, well, yeah, that's what the old man said. So 5 years goes by, I'm thinking I'm strong, healthy, nothing can happen to me. 10 years goes by, 15 years goes by. And then one day I woke up and I was staring at the same thing in the face. And it made me remember what he told me. Specifically, he said, please, if I didn't impact anything to you, please make sure that you check yourself, because I've had it, and more than likely it's probably going to impact one of you. Well, I didn't listen. And so, so to make a long story short, after I was diagnosed and I went through treatment, one thing that I said to myself is that, how can I continue with my father's legacy? And so I decided that anything that I could do to pass the word, anything that I could do to get the word out for other Black men, to make sure that they go for their yearly examination, I was going to do that. And so when doctor approached me and said, hey, do you mind being part of BACPAC? He didn't even have to ask me twice, because that had been my personal story, and that had been my journey. And so I said, absolutely. And that began the partnership with BACPAC. And it's been very rewarding and very fulfilling for me. I've teamed up with Doc on community engagements, helping other prospective prostate cancer patients, walk them through the journey, counsel them. And these days, anybody who knows me, the first thing that I do is talk to them about prostate cancer, the importance of testing for prostate cancer, so that Black men, wherever can avoid the pitfalls that I went through.
Thank you for sharing that.
Yeah.
And I think one of the things that you have highlighted is the importance of knowing things like your family history. And there's this awareness component that you've hinted at. I guess, Victor, tell us a little bit about yourself and your role, and what's your perspective as a younger person working with our team as far as understanding you and I had a conversation last week that really made me realize like the impact that being around this group can have on someone like you.
Yep.
Right?
So my name is Victor Tobin. I'm originally from Ohio. I moved here. I lived here for 7 years, and was blessed to meet Dr. Yaw. I hosted an event called African American Male Wellness Week during COVID, along with I'm the national coordinator for the Renton area for the African American Male Wellness Agency. Was I host a 5K walk and run free health screening for all men of color because we die at such a high rate from preventable diseases that we can prevent if we just know our numbers and take the initiative to go get checked out. Along with that, when we met, we kicked off the week with the health week that we did during COVID was prostate cancer. So that's when it was like, oh man, there was so much stuff I didn't know. But also at the time, that's when I had my first kid. I had my son, and different, Coach O, I'm not close to my father. So for me, it was more so I'm close to my brother and I'm close to my sister, and my brother had been going through a series of kidney failure issues, and he went through a whole life-changing just issue after issue, almost dying, flatlined 3 times. He had to get his leg amputated, he had to get his toes amputated, and he had to get his knee amputated. And it went from the worst to worst to worst to it was I flew home so many times to go check on him for so many different issues when it came down to it. And it was more so of like, okay, for me, my father, our father wasn't ish, me, to be honest, but it's my duty to make sure that my son, now my other son, mother, they know their numbers, and then make sure that it became bigger than me because I'm around a whole bunch of athletes. I'm around a whole bunch of people day by day. So, and I personal train too. So it's only right that I take care of my health. But being around so many different young men that looked up to me, young men and women that looked up to me, it's also important to have them get involved so they understand the importance of knowing their numbers and understanding it's important of when you're in pain or when you're feeling something, it's time to go to the doctor. Me and Dr. Yaw was talking, like I said, a week ago, and I was like, oh, I just turned 40 this week. So yes, it is time for me. So we had a great conversation. I was like, so BACPAC Impact, when we got together, and it didn't, like I said, oh, I'm definitely on board. When Dr. Yaw approached me with BACPAC because of the fact that I want to help our men understand the importance of getting checked out. I want to help our men understand the importance of making that connection with a doctor. And that's the one thing that we don't have in our community is that connection with the doctors. And that's what deters us from going to the doctor. One of the things that deters us from going to the doctor is not having that built-in connection with the doctor. So if we see you in the community, if we see them doing work in the community, not just when we go to the doctor's office, then we're going to be more liable to approach you and also understanding the questions to ask. Coming to events like this, going to, just coming together in a mental health talk in a community where we can have questions and have that dialogue conversation. So that way we know the right questions to ask when we go to the doctor. So BACPAC has been a truly a blessing to me because I just want to help. Like, I want to see us live longer. I want to see us be smarter about the decisions that we make and be able to have that information to provide to people so that way they can grow. So BACPAC it's great because we come together for these events. We talk, you see men learning, you see people coming together that want to help each other out. And that is the main thing that bringing communities together when it's coming to talk about issues that are killing our people, that are killing us as men rapidly. And it's just, let's have a conversation. Let's go get checked out. Let's not be afraid. We can go get the test together, or we can have an event to where we can have these PSA tests, or there's an event that can be had that we can do this together.
So a great message. And I think one of the things you talked about is just normalizing healthcare, right? So that it's not always a fearful process. Let's go back to the conversation we had last week, because it was a lot there, and you work with us, right?
Yes.
So what prompted you to ask me about whether or not you needed to get a PSA test?
Well, I mean, I always think about ever since we started meeting on Zoom a long time ago, and we started
2020. 4 years ago.
I'm like, I'm like doing the math in my head, like, it's coming. So, but it just was as I got older, and I'm in fitness, but as I got older, I started noticing about December of last year, I started noticing I can't get my abs back as fast as I could. That was the first thing. I was like, oh, I said, normally it comes back pretty fast. Now
I have the same problem.
And then I was like, okay, I am approaching 40. I said, so maybe this little approaching 40 thing is real. So, as I started approaching that 40 tick, I'm gonna say, I was like, oh man, okay, it's not coming off fast no more. So, it just something that really, really connects home with me is just more so of knowing my numbers. And after talking to Dr. Yeah, we talked, and there was a death in the family. My wife's mom had passed away, and it was like, oh man, she's only 56 years old, and that hit hard for our family. And me and Dr. I was like, oh, I gotta go get checked out. So when we started talking on the phone, I was like, yes, time. I know. I said I was about to call you and ask you, can I just come up to Seattle? And I don't really want to go to nobody else, but I was like, I just want to come up to Seattle and talk to you and try and get everything together. So that was one of the main. That was like the.
What else did you ask me? Which is important. And you asked me what screening involved.
Oh
right?
yeah, I said, man, what all do I have to do?
Yeah.
Like, what do you like?
What do you mean by what?
Like, let's get in depth a little. Like, what do I have to do? Like, what is going to happen? And most men are fearful of what is going to happen or what that test looks like.
What did I say to you? I told you
just
needed a blood
test.
test.
Yeah, he said just blood, just like one other gentleman said, just a quick little blood test. I'm like, oh, I'm good with giving blood. I give blood right now. I got good veins. I'm like, I'm good with giving blood. So I was like, oh yeah, for sure. But that's the thing that even with me being with BACPAC, I done heard it several times, but at the end of the day, I was like, okay, I'm only 36. I ain't really worried about it right now. I can tell somebody else hit fast, but we don't even do it. So it's basically it's taking that accountability and that ownership in yourself and in your health to be like, okay, yeah, all right, let me pay attention to this a little bit more. And okay, I know I keep hearing, okay, it's only a PSA, give you blood, you all right? I'm like, man, hold on, what else is gonna happen? What's gonna happen after I give blood? Like, so it's those type of things you think about. I'm giving you the perspective from the community and what the type of things is gonna happen. Like, after I give blood, what's gonna happen? You know, so, and those are the type of things we're fearful about.
I think this a lot of what we're working on in BACPAC right now is helping people figure out what they need to do, what they need to know, right? One of the important things we've learned as a group is that the rectal examination, it's become a roadblock. But the first line test really is a blood test. If we got everyone to just do the blood test, which is a better test for screening, we would make a big dent in this. So I love that Victor called and he's like, I'm 40. What am I supposed to do again? Get PSA? And then I was like, yeah. And he was like, and what else? I said, I think that's it, man. Start with that. He was like, good, I can do that tomorrow. Coach O, you mentioned something that's really important, which was your father. Talk a little bit about what you've learned through the work we do about family history, and how has working with BACPAC changed how you think about the importance of knowing family history, breast cancer, prostate cancer, as part of your decision to screen, and how does that impact your messaging? How do you talk to people about it?
Well, one of the things that I've learned over the course of 3 years is the importance of genetics when it comes to prostate cancer. Because I'm the middle of 3 boys, and in my wildest dream, I never thought that I'd ever be diagnosed with prostate cancer, even though my dad was diagnosed with prostate cancer. So for some strange reason, I was thinking that it was going to skip me. And maybe my older brother would have it. But as fate would have it, well, I got it. And one of the things that it taught me was that, genetics is really important when it comes to prostate cancer. If prostate cancer is within your family, it makes it even more important to always always get tested and stay on the stay stay abreast with your health checkups, the need to uh, know your numbers when it comes to PSA. So when I joined, BACPAC, one of the things through some of our outreach and community engagements, one of the other things that I've learned is how much little knowledge is out there when it comes to that. A lot of people are not aware of that. A lot of people, especially within the Black community, are not aware of the correlation between genetics and this disease. And so one of the things that I try to do is everybody that I talk to, I always pass the message along. Everybody that I come in contact with, well, of course, I'm not going to go to CNN and broadcast that, hey, I got prostate cancer. But these days, everybody that I come in contact with who's within my inner circles, I try to educate them on the importance of being tested and on importance, especially if they're within my age group. See, again, I was diagnosed in my early 50s. And I don't know about any of you, but I never thought that, I think the general misconception out there is that, yes, men do suffer from prostate cancer, but much older in life, like when you're in your 70s or your 80s, but never in your early 50s. I never thought that. But here was I being diagnosed with it. And so for me, that was a rude awakening. And I had to get the message out that, look, if you're gonna have a chance to beat this disease, it's very important that you detect it early. That gives you a better chance. In my dad's case, it was not detected early. So by the time it was detected, he had only 6 months, and it was exactly 6 months to the day. So that's also part of my message, that genetics plays a big factor in that. Because of that, if you find yourself in that pool, it's even more important to get tested.
I think it's important to highlight that our prostate cancer research program here at the Fred Hutch really opened our eyes to the genetic components of prostate cancer. I was in training in Cleveland when I saw one of my now partners, Heather Cheng, give a talk. And she got up there and she said, you should ask all your patients if prostate cancer runs in the family, if breast cancer runs in the family, if ovarian cancer runs in the family, if colon cancer runs in the family, if pancreatic cancer runs in the family. All of these cancers have genetic mutations that have been discovered that are linked to prostate cancer. And in about 10 to 20% of prostate cancer cases, we can find those mutations. So it's a revolutionary set of data that we have. And I think the way that you approach your inner circle, I think it's a great framing. What I like to think is we have to normalize health conversations within the family, right? So that there aren't secrets of like, yeah, well, dad was hospitalized for a couple of weeks, when I was young. I'm not sure why. Or what I hear a lot is dad might have had prostate issues. What we really want to get down to is, did dad have cancer or not? Grantley's smiling because we've had this conversation too. Ken, in our patient summit, our research summit, you said something that really stuck with me. if I knew then what I know now, I would have approached things differently. I think, tell me a little bit about, your treatment journey, and what do you know now that you wish you knew then? And how would that have changed some of the decisions you made about screening or treatment?
To be honest with you, I don't know if it would have changed much. My team did make me aware of the disparities, but not to the level that I understand now. Now I have such a better understanding of the breadth of the disparities within prostate cancer. And in fact, I've learned that racial disparities exist across all cancers, but prostate cancer has the highest degree of disparity. I was diagnosed at age 51. So I kind of had an understanding that it could hit Black men earlier. So I did the active surveillance, and what I did during that year is I just tried to get as much information as I could, looking at all my options. And then post-treatment, like I said, I had just a thirst to get the word out, to get the word out to all men, but especially Black men. And that's the joy that comes to me being a part of BACPAC, that knowing that we come from different places, geographically, age, but we're all on the same team. We're all rowing, trying to get to the same place. And that gives me purpose to try to reach back, pay it back, and then pay it forward. Just I told you I relocated to the Bay Area recently, and I've connected with a couple old friends, and we'll be out to having something to bite to eat. And they go, oh, I went to the doctor the other day. I said, oh, by the way, have you had a PSA? I'm always looking for a way to get that in. It's not always easy, but if somebody mentions a doctor, I'm coming right in after them. Another guy I know, his father had prostate cancer, and I asked him if he had a PSA, and he was of the mind that like the home Cologuard test was sufficient. So I was involved in a fatherhood initiative. This is down in Berkeley. About 12 of us met on Saturdays for the month of August. And these men were like 30 to 40, not maybe, my ideal group might be 40 to 50, but still I put PSA out there. I'm just trying to plant that seed. And if it doesn't impact you, maybe you can tell your uncle or your brother or your father. So it's just that ripple effect. And that's what I like to do. I don't even know if that answered the question.
It did. It did. I feel like a talk show host. I'm just trying to keep the conversation moving, So you open up a topic that I think is important, and for a lot of men in the room, I think irrespective of race, but especially I think for high-risk populations, right, which we think Black men belong to. So you come in, your PSA is high, you might have had an MRI, you get your biopsy, we tell you have cancer, but don't worry about it. We're just going to watch it. What was that process like for you? What things gave you confidence to go down that road? Did you think at all about yourself as a Black male, whether that was a safe option for you?
I thought it was a safe option for me because of the way my team explained it. And what they said is active surveillance. The word active is very important. You can't just go home and not follow up or put it off. So I was getting my PSA done every 6 months. We were on top of it. So I felt okay. But then again, after 1 year and that second biopsy, I was like, we're gonna make a move here. I wish I could have gone on active surveillance longer. And if I'd have been, 81 and not 51, that'd have been a different equation. But at my age, I thought, I'm gonna get at this now. And that was my choice for me.
That's a great point. I always remind folks that active surveillance is active, right? As you said, it's different from watchful waiting or observation. We do have other modes of watching cancers that are less intensive. And 50% of men who go on active surveillance get treated. Right? So sometimes I think of it as a deferred treatment. That time without treatment can be valuable, right? That's time without being exposed to the risks of treatment. So, Victor, what is your favorite backpack project that you've worked on to date? Can't say all of them.
No. I would say the initial part of really getting out in the community. That's my thing. What I enjoy networking and connecting with people in the community. So getting out to the community and getting the people together to actually do the research. Our first project, I'll probably say, would probably be my favorite because we actually had to really put in work to get people to come to the table to get interviewed, get screened. Dr. Yaw came to my church. We set up a table at my church, hand out flyers. We got in front of people so they could see us out in the community, and that's what they want to see too. So having, Dr. Yaw come to the church, set up a table because we needed to get a list of volunteers together. Getting that list of volunteers together when he came to the church was big, and it created the conversation going. And from there, we got men that had prostate cancer, just got through recovery, and I believe a few that was actively just learning about it and going through it. So it's just it was those type of things of actually being like outside in the community, outside and doing the community activities and those type of things that help raise the awareness to a lot of people, a lot of men to actually come and actually be able to speak about it. Because honestly, even with us being at the church, I wouldn't have known the men that came forward to have prostate cancer if we didn't do that. And they would have never said nothing, and they would have never spoken. They were like, okay, I went through it and kept it to myself. From that, I will say one day I was walking in, my son, Yeah, me and my son at the time, we were walking into Red Robin's, and a guy approached me as I was walking. He was like, hey, you the dude from church. He was like, I just found out I got prostate cancer, man. He just started talking to me like just out the blue, and it was just good to see and good to have someone talk to me. They knew that I was from the church, and I didn't have a full blown conversation with him. He just knew that me and Dr. Yaw was at the table getting a list of people trying to get volunteers together to start the research program, so we could start this program, and we could start to just getting the information and knowledge and understanding why men don't know as much, why we don't want to know as much, and why we're shying away from it, and what we need to do to learn more about it. So I'll say that was my.
Yeah, the first study was a lot of fun. You guys are not aware that Victor and I met on Zoom only, right? So we worked for about a year and a half. We wanted to interview about 30 Black men that were between the ages of 30 and 65 to understand what their perspectives were on prostate cancer. And so Victor was helping us connect in the community. And so, yeah, lots of Zoom meetings, hour long, every other week. And then all of a sudden one day, he's like, you got to come to the church to get the word out. So, all right, we'll do it. And I'm standing there, and here comes Victor, and I realize we've never actually been in the same physical space. So it was a great time. That church event was really wonderful. And as you mentioned, I think what I realized from that is if we create space for people, they'll utilize it. Because a lot of the guys, hey, I've been treated, or I got treated 5 years ago, thanks for being here. They hadn't had a chance to be able to voice that. And so that was a really good time. Kojo, what project are you working on right now?
With BACPAC, so I'm part of the advisory board for Combat PC.
And tell us a little bit about what you've enjoyed in the Combat PC learning process so far.
So again, highlighting on my personal mission, one of the things that I've enjoyed about Combat PC is Combat PC is we're trying to develop a toolkit that that would have all the information necessary to educate folks about how prostate cancer, exactly what you talked about. And so being part of the panel and going through it with the clinicians, the researchers, the scientists, it's for me, it's very rewarding because you get to see a project from its inception to its conclusion. And for me, coming from a patient advocate point of view, I'm able to relate information to the rest of the team what a patient would like to see, what a patient would want to know, what are some of the barriers that that some of us Black men we go through. One of the things that that you mentioned when you talked to Doc was that one of the questions that you asked Doc was that, hey Doc, what else do I have to go through? And then, you know, I'm sure at the back of your mind, you had some things that you were a little bit apprehensive or worried about. And those things are real. Those things, I went through it. A lot of my friends go through it. A lot of my, African-American friends, we all go through it. And it's a hindrance. It becomes a barrier to the reason why some of us don't want to go get tested. And so from a patient's point of view, I enjoy being part of the advisory board, so I could let everyone know from a patient standpoint of view what it's important, what is necessary for us to overcome that barrier, and in developing the toolkit. So for me, that's been very rewarding and also very enriching because I come from an engineering background. I work abroad. My whole career, I've been in the engineering discipline. So to step out of that and do something like this, it just broadens my perspective on things, and also I can have appreciation for what the doctors go through. So it's been good so far.
Good. We're now going to have a meeting in Honolulu. I feel like you were buttering me up at the end there.
I was looking forward to that.
So at the very end here, I just want to kind of go through, have you guys tell me a little bit about yourselves. And, we interview candidates for jobs all the time. I always ask them, what do you like to do for fun? So I want to hear from you first, Ken. What do you enjoy doing for fun? How's that changed, if at all, as a cancer survivor for you?
I'm gonna share just one little mini horror story first about how doctors fail to communicate with some patients. We had the workshop a couple of weeks ago. I shared the story. Liz was in my group. So I was about 45 and I went in for a physical. And I was supposed to be lucky to have this doctor. He was a new hot shot. And he said, well, your numbers are a little elevated and I've been told I have small hands. And I was like, and so I kind of knew the joke about the glove, but I don't even know if I knew what a prostate was. And I didn't know where it was located. I didn't know how you get there. And I was embarrassed because I didn't know the joke. So I kind of froze. And I ended up not going back to see that doctor over a period of time. So when I went back to go to the doctor, they said, I had separated from him and they assigned me to another doctor. And this is the primary care physician. I had like a 13-year relationship until he retired on me. And he was a great guy and he might've saved my life. So, and part of me wants to try to find that first doctor and just share with him what the impact of that conversation, and maybe he could do it differently going forward. But what do I do for fun?
Talk about a transition. Well, I will say this, right? The relationship between you and your doctor is like sacred. Right? Yeah. And I think if you don't have that good feeling with the person taking care of you, you're entitled to looking for a second opinion or someone else. And that's especially true in cancer care. You got to believe in your team. You got to feel comfortable with your team. And it takes a while for me. I've got to know like when Donnie comes in the room, I'm all jokes because it's Donnie, right? But you know, when I meet someone for the first time and we talk about sensitive things, you have to earn that trust to have a relationship be any different, and you've got to make sure you're on the same level playing field. So thank you for sharing that. I think if there are any clinicians listening, for those of
Please.
you who may be doctors someday on our team, you know, it's an important message because that's a terrible joke.
But yeah,
I got
and so
small hands.
right, right, and he kind of said it with a little sinister smile, and I was like, you know. And then, so then when I was on active surveillance, I'm meeting the C doctor, I'm meeting the external beam doctor, I met the surgeon, he was my urologist. So I'm going to talk to the external beam guy. Now, hey, this doctor's getting ready to retire. And we just talked, he said, well, let's do a DRE. I'm like, what is it with these people? I mean, what's the rush? You know, let's go to lunch first or something. But anyway. And I've been treated, and I mean, I've never had a DRE. I'm not saying I would be opposed to one, but I didn't understand why that had to be the initial point of contact for these people. Right, let's do the blood test, right, Victor? Let's just do the blood. Okay. So
You like DRE?
what's that?
You like Dr. Dre?
Dr. Dre, I like. That's different. So I physically for fun, I'm a frustrated golfer. I used to golf a lot more. I used to play better, but now I take my time. You know, I look at the sky and listen to the birds, and I have a much better time. It's not so score focused. Like I didn't have a good time if I didn't shoot well, and I'm not even good enough to get upset if I don't play well. So golf is my hobby, and then I enjoy the occasional play or dancing. A couple months ago I got to see Alvin Ailey and the Dance Theater Harlem kind of back to back. That was amazing. Well, that's my idea of fun.
Love it. Did that slow down at all for you during treatment? Golf and activities and.
I handled it pretty well. I mean, but that commitment of Monday through Friday. I had 39 sessions, and then I was still working. So that was my focus at that time. A lot of things kind of went to the side. Oh, and that's the other thing. They said, you should work out and exercise, and that would help. Well, I didn't quite, got Victor over here, but then there's me. So, yeah, I didn't do a whole lot during treatment, but that was okay because treatment was my #1 focus.
So Joe, who is the best bass player of all time, and why is that Flea?
Oh, why is that Flea? Well, I don't know about that. I don't know about Flea being the best bass player in the world of all time.
Yeah, just said.
Yeah, I think there will be a lot of scholars who would probably disagree with you.
Scholars.
Yeah, bass scholars.
Who is your favorite bassist?
I'd have to say Marcus Miller. Yeah,
Now Victor.
So Victor Wood. No, hold on. Let me clarify. So Victor Wooten is, I don't know whether there are any musicians in that house. He is technically gifted beyond anything that any of you will possibly ever see. I mean, this is a guy who solos, and in the middle of his solo, he does a backflip with his bass. Exactly. He is technically gifted. I mean, he's a 5-time Grammy Award winning bassist. But the reason why I say Marcus Miller is because Marcus Miller, when you hear him play, he's the first bass player that I heard on a record that I said, I didn't care. I didn't care about who was on piano. I don't care about who was on drums. I didn't care about who was on the horn section. I just wanted to know who was on bass. And I was only 16 years old. Now, the reason why I say that is because when you listen to him, he's the most gifted, all-rounded bass player. He's worked with everyone from Miles Davis to Luther Vandross, to name it, everyone. So when I say he's the best bass player, because when you hear him play the bass, you know you've heard the sound of the bass. When you hear other people play the bass, you know you're hearing the sound of an instrument. Now, here's the difference. When he plays the bass, you know there's no distinction between him and the bass. That's what sets him apart.
Whew,
Check him
all
out.
Hey, can you can you give a description of me as a surgeon like that? Like me and the robot? We're gonna film this commercial for the Fred Hutch. I mean, wow.
Yeah. So I mean, I'm sorry, I can go on and on. And I have a pleasure of knowing both of them personally, on the personal. So yeah.
So how did your love for music change during your treatment? Were you able to keep playing and be active?
So unlike unlike him, for me, it did change. Some of the things that I really enjoyed doing was, of course, playing music. I used to play a lot in churches. I used to gig around a lot in town, local jazz joints, And one of my other fun hobbies that I love doing is flying airplanes. So everything came to a grinding halt. In terms of playing, I couldn't really play, especially after I went through, prostatectomy. After that, it became my main focus on trying to heal myself before returning back. And in terms of flying, I just recently started flying because one of the things with Big Brother over here is he tends to be very, very nosy. That is the FAA. Too nosy. So you go through anything like that, he wants to know what you went through, when you went through it, what was the results of it. So it takes a little bit more time in getting your medical through for Big Brother FAA to bless you again. So I went through that. It took a while. So I'm not clear to fly, but yeah, it did. It did affect me in terms of playing. I still haven't returned actively, but I'm still actively listening. I still actively attend, jazz shows. But it kind of slows you down a bit, which it did. Yeah.
Sounds like we need to get a backpack band together and get Kojo back on the stage.
Absolutely. I'll be up for that.
Next year's symposium, you heard it. Victor, final message. What do you enjoy most doing in your free time these days? And yeah, what is your message to young Black men about prostate cancer screening?
Well, first, what I enjoy doing most is working out. But now it's more so of not necessarily as me. It's my son. He's a split version of me, my oldest son. He doesn't sleep in, which makes me mad. But then it's like, so now I just know around between 6:30 and 6:45, like clockwork, whether if I'm up in the morning working out, trying to get a workout in before he gets in, he's going to be up, he's going to run to the garage, or I'm going to hear some feet run around the house and think somebody done broke in. So I'll take him out. We'll go take him out to the track. We'll go for it. We'll start running. So what I love to do now is just work him out and get him ready.
Training the next generation.
Get him ready. So since he wants to get up all the time, we go kick the soccer ball around, or I'm working on his baseball swing now. But and he's in training mode now. His push-up game is nice, and just start getting him going. So that's what that's he's 4. It's a problem.
You want to train my kids? You will have zero luck.
He's 4.
My daughter yesterday said, I love Saturdays because I get to sleep in, sometimes till 9, 10, or noon.
Oh no, he's 4 years old, so he gets up, and it's time to get to work. We out on that track.
We signing NIL deals.
We might as well. I missed the boat, so he might need to get some of that. But that's why I love just really that, and I love to go fishing too. So still going fishing, and I like to do boat fishing, going out in the ocean. I want to try and have a fight. Still work out too, but it's trying to have a fight with with going fishing. So those are the type of things that I love to do. And you said my last message. Oh, and my last message to young people, men in general, men, women, and the younger generation is come together, start taking ownership in your life, and start taking hold your life to value. Understand that is so important again for us to get checked out. It's so important for us to create a space like this to have conversations, whether you have been through it, went through it, fighting through it, and still learning about going through it. It's good to hear Kojo's side, the fact that he's been from his father point of view. My point of view, again, is different. I wasn't around my father, but also my father passed away in May, so I still never got a chance to ask him previously, what happened with him, or what other health issues was going on. And I never knew those type of things. So that's what's important, is to, again, things are generational. So figure out, learn, and don't be afraid to go do the research for your family, because we are leading the next generation. We need to continue to help the next generation be stronger. We need to help them be more mindful of certain things. And it's very, very important for them to channel their mindsets on the life side of things and not just the social media realm of things. So for me to talk to myself, the younger me's, and the other men and women, is when you really think about your body, when you really think about, your growth, we want to live long. The goal and the object is to live long. So it ain't no old school, oh man, the goal is to get old. So that's the ultimate goal. So take accountability for yourself, because we have to look ourselves in the mirror and say, okay, I felt this, but I waited. I felt this and I waited a week, and I waited another, I'm gonna wait till Friday. Friday, I'm gonna wait till Monday. It's gonna get better. And then don't wait till it's too late. Take ownership in your body, take ownership in yourself. And also don't be afraid to push your friends along, bring them along with you. Bring your friends, bring your brothers, bring your sisters, bring your family along with you, because we're supposed to get old together. So let's learn together, let's grow together. Let's come to spaces like this and communicate and have a community to talk together, and let's all do it together. So that way we can live longer.
Love it. It's a great message to end on. Victor, what is it? What do you sign your emails with, by the way? At the very bottom, it says something about putting in the work.
It says, what did I say? I know I say it every day too. Now you actually, work comes when you put in, no, I said results come when you put in the work.
Results come when you
put in the work.
Every
that's what I live
time
by.
Email Victor, I get a response usually that's like, looks good. And it ends with results come when you put in the work. And
I don't see too much emails.
I feel like that's become my little motto. Results come when you put in the work. So I feel like that's what we're doing here with BACPAC. I want to thank these gentlemen so much for sharing a little bit about themselves and the work they're doing with us and their cancer journeys. Thank you very much, gentlemen.
Thank you.
So I'm going to have a few closing remarks here, just a few slides to end the day. Hopefully get us out a little early. Apparently Michigan and UW are playing football today, for those of you who care. Were there any questions that you guys wanted to ask? Okay, if not. So I'm gonna move this here. So one of the things about BACPAC that I think is unique is that we started from scratch, right? So I had a few questions about, what are we doing to get more Black patients involved in clinical trials, repositories? How are we trying to get the and all of those things I think we're trying to build now. And I think one of the first things we had to ask ourselves when we were doing our research was, how did we want to think about prostate cancer disparities, right? I think we heard from Ken and Kojo and Victor that their lens has changed a little bit about this problem. And I will be the first to admit my lens changed when I came to UW. Because when I was in training, I was really focused on the biology only. We just had to find the right genetic test or the right marker, and we could make a dent in getting people treatment. Part of that was because I was at an institution that had limitless resources. So I wasn't used to having to think about what it was like to deny someone care or what to do if someone couldn't afford care. Because if they could get into that particular hospital, they had enough money to take care of everyone. But the truth is, most of our disparities reflect structural, social, healthcare factors, and in addition to the biology, right? And so I think we took for how we wanted to approach our research very seriously and focused a lot of our efforts on trying to make sure whatever project we did along the entire continuum of prostate cancer care, that means when you develop a cancer, how you get diagnosed, what treatment you get, how you live with prostate cancer, how we treat your recurrence, how we treat your stage 4 cancer, and whether or not you unfortunately are succumb to the disease. We wanted to make sure that we thought about all of these domains in the patient experience and making sure that we supported them. And to do that, we really needed to build a pretty diverse apparatus. And I think Dr. Dole said something that really resonates with me, that you got to get comfortable learning and leading at the same time. And that's happening from everybody in the team. So those who are involved in BACPAC projects know that you come on board and then the first 6 sessions are training, right? We're teaching you the language, we're teaching you the research approach. And because there's got to be that bi-directional learning. But also for us, we had to hire different skill sets, right? And I think on a sidebar conversation, I said to somebody that I didn't even know what an implementation scientist was until 2 years ago, it felt for me, right? That was someone that I need to collaborate with, but we now know that we have to have that as a skill set. What makes us really unique as a health disparities, health equity research program here at UW is that we have world-class expertise in all of these domains, and everybody works together. And I wanted to highlight a quick example. Our first 2 symposium have happened at a time where we're still analyzing all of this data we've gathered. I hope future symposiums will include us updating you on the progress we're doing in the research that's occurring through BACPAC. This project is funded by the Patient-Centered Outcomes Research Institute, also known as PCORI. Dr. Dole alluded to them. We call it EDAB, which stands for Early Detection Advisory Board. And the goal is really what we wanted to do is build a team of patients to help us figure out how we could identify the top research priorities in early detection for prostate cancer. That seems intuitive, right? But what happens typically is I get in the room with a bunch of other urologists and we were like, hey, we should do a screening trial and we should do it in 50-year-olds and we should do it this, but devoid of community and patient perspective, right? So we wanted to build a team. We wanted to develop a resource to ask actual people, actual patients and caregivers, so people that are social support, this question of what research priority should we have? And then we wanted to take what we learned from that and develop a study that we would then pursue, okay? This is the same thing that Ikana and Sister did. So Dr. Dole got a group together, they surveyed a couple hundred people, they came up with some priority, and then they developed the Sister study because that was the top priority that they identified, was that people needed social support. So we were really lucky. We put together a fantastic advisory group. Some of the members on the slide are in the room today. And then that team helped us with the recruitment for the virtual research community. And this is one of the postcards that we had for recruitment. If you don't notice that blurred out, very beautiful dome, that's Ken. And then we have John, who's somewhere in the back, this is actually pictured from the symposium last year. Part of the reason I'm highlighting this is just to emphasize how important this approach is. We told this federal funding agency that we wanted to build a virtual research community of 300 people. And when we pulled that number out, we thought that was like, seemed important enough, but like it was a reach number, right? 300. When we put out the call through our network and our coalition through BACPAC, we ended up with actually 2,500 people that signed up from across the country, 95% of them identifying as Black. And our first survey had over 1,200 responses. This is a distribution across the country of people who signed up for the virtual research community. I know there's no scale here, but the darker the number, the more people, right? And so there's certain regions of the country where we had, hundreds of people sign up. But it really is a testament to the people you see in this room that are involved in BACPAC that trusted us and the work that we were doing to share the invitation to participate through their networks. And as a result, we ended up with this really phenomenal response. So we sent the survey to people who had identified within the virtual research community as Black prostate cancer patients or caregivers to Black prostate cancer patients. And we had vetted a set of questions with our advisory board, with some experts across the country on topics for early detection. What does that mean? Well, should I get a genetic test before I get a PSA, right? That's something that we could study. Should I start screening at age 40 versus 55? We could study something like that. What's the impact of having like a trained navigator help me when I get my PSA test? We could study that, right? So we had, 15 topics that we put together. And one of the things that was really interesting about our approach was like everything happened with our as I like to call them, cancer survivor scientists. That's who was in the room, right? And our team would put everything together, vet it for a long time. Like, oh, this looks great. And then we put it in front of the guys and they'd be like, hey, what do you mean by that? That doesn't make sense. I wouldn't say this. What is that sentence? And so we kept workshopping it. And we actually came up with a lot of innovative solutions of like how we framed it. We had a little prompt that kind of explained like the general scenario for research, and we sent the survey out. And what I want to show here is that all the topics that we sent out, people thought were important, okay? So I know you can't read the questions, but all the topics that we chose were important. And the thing that you don't see here is that out of the 1,500 people we invited, 1,200 people responded. Now, we told this agency that we were going to have 200 people complete the survey and that we were going to pay 200 people. So I had this meeting where I was panicked. I was like, do we have money to pay 1,200 people for completing a survey? But it was a good problem to have, right? These were the top 6 topics that came out. And we were able to take the top 4 of those 6 topics, actually these top 6 topics, and distill them into 2 main priorities. It seemed like people wanted us to either focus on a study that was looking at what you do next if the PSA was elevated. So do you get a blood test or do you get an MRI? Or this idea of how we screen smarter, right? Start younger, maybe adapt based off of what that first PSA number is. So we did a second round survey, and in that second round survey, the top thing was, when should we start screening and how should we screen? So our team came together here on the other side of campus in September, and we hashed it out. And I think I learned a lot in that conversation about how we should approach a clinical trial that's going to address screening, and the do's and don'ts on how we would approach people. What are the key things? One of the things that someone said is, I don't feel comfortable with a study that gives some people everything and the others nothing. Like, I want to help everybody. Donnie's smiling because he knows who said that, right? And so we're really excited about the next phase of this, which is going to be building towards a sister-like study within prostate cancer in partnership with BACPAC. If you don't believe in this method that we're taking, a good survey has a response rate of what, 10%, 20%? Our response rate was 85%, almost 90% response rate, okay? So we sent it to 1,500 people, and over 1,200 responded. So it is a testament to the value that you all bring to the work we do. And I think we'll see that further rewarded when we approach a funding agency to fund a trial. These studies are expensive. They cost millions and millions of dollars. But I think because of your voices and your commitment to what we're doing, we will find someone very eager to help support work that will make a difference. So with that, I want to say thank you. Special thank you, okay, to Ritu and Meredith and their team. These guys are incredible in hosting this event for us. And so then I'd be remiss if I didn't thank my team, the research team at UW. We've got Liz Sage, Sung Min, Kim, and I don't know if John Masembe is still here, but they, Saturdays are usually sacred time for us all. And so I'm really thankful that they're here. And then lastly, for you guys, I mean, I know you have family commitments, football games to watch, and you guys all took time out of your schedules to be here. So thank you very much.